because we know that there has been some changes over the last few years in how we try to approach the management of our patients who are challenged with this condition. So I hope to highlight changes, to discuss pre-rheumatoid arthritis, to outline the evaluation of a patient, review treatment options and guidelines, and review disease activity measures. First, I'm going to start with a case. And so I present to you a patient who came to me earlier this year. She's a 56-year-old female. We refer to her as CC. She's right-handed, lives alone. She works as an admin assistant, and she initially presented to the healthcare system 3 years ago. She went to her local GP. She lives in central Jamaica, and she had noted that she was having pain and swelling to her hands and knees for about 6 months. The GP evaluated her, gave her Voltaren for relief of her symptoms, and sent her to do some lab studies. On return, review of the lab studies revealed her hemoglobin was 10.7, so mild anemia. She had a borderline leukocytosis. Platelets were fine. Her UNEs were also normal, as was her blood sugar. But her ESR was significantly elevated at 86, and her rheumatoid factor was also elevated with a titer of 1 in 32. When she went for her return visit, after reviewing this, the GP said to her, "You do have rheumatoid arthritis." But he maintained her on the same treatment of the Voltaren. No disease-modifying therapy was offered, and she was not referred. The patient wasn't very familiar with the condition, so she continued to take the Voltaren, which was giving her some symptom relief. But however, she noted as time went on, she was having changes in her fingers and loss of function. So she started to have problems with doing her daily activity, and then also even things like housework. She started to have difficulty with tasks at work. She does a lot of computer work. And then even further on, she started to notice that she was having difficulty with moving some of her fingers. So she presented to me early this year, and she was actually referred through an orthopedic surgeon because her sons realized that she was really declining, and they had a local orthopedic doctor. So they said, let's take her to the bone specialist. When the surgeon referred her to me, she was sent with the labs from 2019. Her history with me was consistent with rheumatoid arthritis, and she continued to have active symptoms. And in the physical exam, apart from showing synovitis, it was significant that she could no longer extend her 3rd through 5th MCPs on the right hand and 4th and 5th MCPs on the left. I started her on prednisone and methotrexate. When she came back to me about 3 months later, the patient's synovitis was improving, but of course, her functional loss remained. She continued to see the orthopedic surgeon for a condition known as Von Jackson syndrome. And unfortunately, at this point, 3 years later, the patient is applying for a claim on a disability insurance she has because she has decided she has to resign her job. She's getting a lot of complaints that she's not performing competently, and she'd rather resign than be fired. So we have somebody now leaving the workforce prematurely. So just to say it, Von Jackson syndrome is a condition in which you may see a hand that presents like this, where you notice that at the MCPs, there's loss of extension of some of the digits. And it's a rare condition in which you have sequential atraumatic disruption of the digital extensor tendons, starting on the ulnar side of the wrist with the extensor digiti minimi and the extensor digitorum communis tendons of the small fingers first being affected, and then it moves radially to affect the 4th finger, the 3rd finger, etc., if the underlying cause is not addressed. And rheumatoid arthritis is the most common cause for Von Jackson syndrome. So I put this case here to say, did we as a health community fail this patient? Was it that the GP failed her in not referring her? Or is it that the rheumatologists are failing the GPs? We're just not getting the word out enough to say that, hey, these patients need to be proactively treated. And also, did the patient to some extent fail herself? Our ability to let our patients know that they're their own advocates, and if they don't get a reasonable response the first time, they should look for care or help elsewhere. But I think the most important question is, how do we not repeat these poor outcomes? So as we go through the didactic part now, I want you to remember CC and apply what happened to her and see what we could have done differently or better. So as you all know, chronic rheumatoid arthritis is a chronic systemic autoimmune disorder. It's the most common form of an inflammatory arthritis seen in clinical practice, and it's characterized by persistent inflammatory synovitis leading to cartilage damage, bone erosions, joint deformity, and disability. And in about 30 to 40% of the patients, if they're not managed properly, they go on to develop multi-system extra-articular manifestations. So over the last couple of decades, we have looked at change in our approach. And out of that has come two important paradigm shifts. The first is a window of opportunity that looks at early treatment. And the second is treat to target that looks at giving the patients the best possible outcome. The goal is remission or low disease activity for patients. And we've also recognized that management can and has been optimized remarkably with the introduction of biologic agents and small molecules, and by recognizing that optimal treatment allocation depends on the identification of prognostic and predictive factors. So if we look at the window of opportunity, it's based partly on the observation that in patients with established disease where joint damage or disability has occurred, treatment is less effective than in patients with early disease, and early disease is defined as less than 12 weeks. And so the window of opportunity is based on recognizing disease early, during which interventions, treatment may abolish symptoms and prevent or limit functional loss, limit joint deformities, and therefore long-term disability, thereby reducing also the long-term cost of care and improving the quality of life of patients. So how are we doing? This graph here is a good indication. It's not from the Caribbean, it's actually from a Danish registry called Dane Bio, but it looks at a 10-year span from 2000 to 2011 in terms of the average time it took to diagnose patients with different inflammatory arthropathies. So the bottom line in blue is actually the line for rheumatoid arthritis. And what we see is that over that 10-year span, they've reduced the diagnostic delay from 2.5 years to a roughly 5-month period, which is a great improvement. What I find even more impressive is the fact that even other arthropathies such as psoriatic arthritis and even ankylosing spondylitis, which we knew notoriously used to be missed, has also seen a dramatic improvement. If we look, we move from 5.5 years to almost about 6 months. These patients are being picked up. So we're certainly doing better, and we want to even improve on that. I don't have data from Jamaica, but I can say I know that we are also doing better because I get referrals in which I see patients just with modest synovitis, and I realize our GPs are doing better. We have the outliers who still don't send, but certainly we're on the right track. And then another interesting thing is that outside of just waiting for patients to come up with classic rheumatoid, there are thought leaders who feel that we should actually capture these patients before. So just in the same way that we have pre-diabetes and pre-hypertension, where we intervene with lifestyle modifications or modest medical management, we have this thought now in rheumatology in reference to our inflammatory arthritis. So that preclinical period of disease precedes apparent classic rheumatoid, where we get florid synovitis. And it really encompasses the interplay between genetics and environment that leads to the development of disease-related autoantibodies. And also the patients may have vague, non-specific joint complaints. But as I said, it is a good place to start modifying behaviors or risks. So for example, if the person is a smoker, you encourage them to stop. If there's dental issues, you deal with those. If the patient is obese, deal with weight management, dietary changes. And what we recognize is that in doing this, we delay the progression to full-blown rheumatoid and structural damage. And we know with autoimmunity, time matters because cumulative damage occurs over time. And we know that radiographic changes start as early as 2 years into the disease. So it's interesting that I went to a meeting in March in Mexico City, and there were 2 thought leaders from Europe, and they are now practicing routinely in their clinics that once they see a patient come in APCA positive, that's the anti-CCP antibody positive, with a long history of arthralgias, they feel it is appropriate to institute methotrexate, because CCP by itself is a pretty sensitive marker, and it also prognosticates that the patient is likely to have an aggressive course. We don't have any evidence that it will prevent progression, but it certainly seems to delay. And then when we look at treat to target, that was the other paradigm that we're relying on to guide us. It's designed on improving care, and it's based off of extensive literature review, consensus conferences. And once again, it mirrors the concepts we use in under NCDs in how we should treat our patients. And so treat to target relies on tight clinical control using disease activity guided treatment measures and strategies to aid in making therapy adjustments which are associated with higher rates of remission. Abatement of inflammation is the way to achieve these goals. The primary goal is to maximize long-term health-related quality of life through control of symptoms, prevention of structural damage, normalization of function, and social participation. Treatments must be based on shared decision-making between the patient and the rheumatologist, and the patient has to be appropriately informed about the treatment target and the strategy plan to reach this target under the supervision of the rheumatologist or whichever treating physician. So the primary target is a state of remission, and clinical remission is defined as the absence of signs and symptoms of significant inflammatory disease activity. And while remission is the clear target, based on the available data, we realize that we have to accept in long-standing disease the alternative of low disease activity. And until the desired target for that patient is reached, drug therapy should be adjusted at least every 3 months. And thereafter, when the target is reached, it should be maintained with monitoring. A validated composite measure of disease activity must be chosen and documented regularly in clinical practice to guide treatment decisions. So what we're saying is, in the past, we used to just use our individual judgments. The patient was with a walking stick the last time. Now they're able to walk independently, not so many swollen joints. They're doing better, and you just maintain. Now we want to have objective measures and targets that give us precise ways of managing these patients. And the choice of the composite measure of disease activity and the level of the target will also be influenced by other factors for a particular patient, such as comorbidities, patient personal factors, and drug-related risks. Structural changes and functional impairment also need to be considered. So we're not just relying on calculating a number, and that's the essence of it all. We need to look at the patient as a whole. So these now are the measurements or the disease measures that have been validated. And there's 6 of them listed here. There's also the thought that it doesn't really matter which one you choose. You choose based off of what is relevant to the setting in which you practice. But whichever one you choose, you're going to stick with it and you're going to use it throughout the course of managing the patient. So if we look at these disease activity measures, each instrument has a number of components. And what we do is we take the components and you either do a summation or a logarithmic calculation, and then you come up with thresholds, which will then guide as to whether your patient has reached remission or low disease activity, or whether they're still in moderate disease or high disease activity requiring treatment adjustments. If we look at the clinical disease activity, the simplified and the DAS, we see that all 3 have in common a tender joint count, a swollen joint count, and a patient global assessment. And then their differences include the clinical disease activity index requires a physician global assessment. The disease activity score of 28 joints requires an ESR, and there's also a DAS that has CRP. And then the simplified disease activity requires a CRP. Another fairly commonly used disease activity measure is a rapid 3 score, and this is the one that I use. It is a multidimensional health questionnaire, so it really relies on the patient providing the information. And it has 4 components to it. The first looks more at daily activities and how they're affected. Then the patient is required to give you a pain score. Then they do their own basic joint count. And then they do a kind of global assessment as to how the illness is affecting them. The shortcoming of this is that it relies on patients who have fairly good health literacy. And if you have coexisting pain issues such as secondary fibro or secondary osteo, you may get scores that are higher than what truly depict the rheumatoid disease activity. So who gets rheumatoid? We know there's a prevalence of 1 to 2% in the population worldwide. We believe from publications in the past that Jamaica is closer to the 2% end. It may affect people at any age, but most often between ages 30 to 50. And there is a predilection towards female in a 3-to-1 ratio. The pathogenesis, as with most autoimmune illnesses, is still a work in progress. It is complex and not fully understood, but we know that it's a combination of factors, including genetics and the environment. And when we say environment, it also means behavioral issues. There are over 100 gene loci that have been identified, and I've just listed 4 of the more well-described ones. The shared epitope we know conveys a major risk. HLA-DR4 also a significant risk. And what is interesting is that even though we know there's a lot of genes involved, we realize that even when you add up the risk from genes and hereditary factors, for seronegative rheumatoid, they only account for about 20% of the risk, and for seropositivity, somewhere between 40 to 50% of the overall risk of the disease. And even when we look at twin studies, the incidence of developing rheumatoid is really not that great. And so that, along with random events in nature, makes us realize that there has to be some other major player. And that is where the environmental factors come into play. Smoking has been one of the best defined risk factors. And it's interesting, it plays a role in so many ways. So first of all, smoking results in epigenetic modification, where we have citrulline replacing arginine. And then on top of that, when you citrullinate proteins, that HLA shared epitope, which brings a lot of risk, seems to bind more to citrulinated proteins. So when you have a smoker who has 2 copies of the shared epitope, we find that there's a 40-fold increased chance of developing rheumatoid. Other things that are clearly triggers for manifestation of the disease are viral illnesses, the association with microbiomes in various parts of the body, the gum, the gut, the lungs, low vitamin D levels, female sex, obesity, air pollution, and stressors, BAM, mechanical and other forms of stress may trigger manifestations of the disease. I always like to put this picture in my presentations because it just really simplifies but brings together what's going on inside the body for us to then see a patient present with rheumatoid. So you have susceptible genes in the individual, there are environmental factors, they come together, resulting in epigenetic modification. There's altered post-transcriptional regulation. There's loss of tolerance and recruitment of immune cells. And later on, this leads to the transition to arthritis with synovitis, structural damage, and coexisting comorbidities associated, such as vascular disease, bone disease, cognitive issues, and disability. I'm sure we're pretty much familiar with the clinical features, so I'm just going to run through. We consider rheumatoid if you've had your joint symptoms for greater than 6 weeks. The pain is worse in the mornings and with inactivity. Morning stiffness is prolonged, at least 30 minutes or more. Palpable synovial swelling and joint tenderness on exam with squeeze test, reduced range of motion, deformities, symmetric and a polyarticular arthritis is a classic description. But we know that there can be phenotypic presentation, and especially early in disease, if a patient comes early, you may not see that classic symmetric polyarthritis. Typically, rheumatoid involves the wrists, the MCPs, PIPs, and also MTPs. The knees, shoulders, elbows, TMJs are also involved, as are the AC joints, acromioclavicular, sternoclavicular. Remember that in the spine, the cervical spine is where it tends to be involved, as the disease tends to spare the thoracolumbar spine. Typically, it spares DIPs and it spares SI joints. Remember, the patient may also complain of systemic features such as fatigue, fevers, anorexia, weight loss, and these intermittent sore throats. So I put these pictures up to make the contrast of where we should be capturing our patients in today's world, which would be the photo and the radiograph on the left and not the ones on the right. So if you look at the photo, we see a patient who has subtle synovitis. We see subtle swelling of the fingers and hands, and a third PIP, you can see a little synovitis peeking out at you. When we look at the radiograph, we see soft tissue swelling. We see some modest periarticular osteopenia with the hyperlucency and some joint space narrowing. We should not have our patients coming through the door or being referred at the time when they look like the hand on the right, when irreversible changes have occurred, where nodulosis is there, where deformities on radiographs are clear, including the bottom radiograph that shows a large erosive area. We still need to know what are classic rheumatoid changes. So I will still put this up to remind us of the Boutonniere's deformity at the top, where you have hyperflexion at the PIP, and then the swan neck, where the hyperflexion is at the DIP and hyperextension at the PIPs. Remember, the feet are important clues to the diagnosis as well. So if you should ask the patient, have you noticed any changes in the feet? If you see splaying of toes, that can be a good clue that there is some synovitis involving the MTP rows. In terms of extra-articular manifestations, as we treat our patients better and earlier, we see less and less of them. So we don't see patients coming in with as many rheumatoid nodules, but nonetheless, the areas that tend to still be quite often affected are skin, the eyes, the lungs, hematologic system. And in terms of neurologic system, we do see patients who come in with the entrapment neuropathies. And we always have to remember that C1 and 2 subluxation, not commonly seen, but I have seen a couple of cases. The other areas of the body are less so affected, but we have to bear them in mind as atypical features of the disease. So what should your approach be if you have a patient in your office and you believe that this may be rheumatoid arthritis? Basic workup should include a CBC, looking for normochromic normocytic anemia, thrombocytosis, leukocytosis, get a baseline renal and kidney function, and that is more for safety of if you're instituting certain types of therapies. We want to have some evidence that there's systemic inflammation, so ESR-CRP would be helpful, though non-specific, and they're useful also to use as a guide through therapy and how there's a response to therapy. Our traditional rheumatoid factor should be checked, as should be the anti-CCP. And there are newer tests out there, not available here in Jamaica, but I'll just mention that there's a 14338 protein test. It's a marker of synovial inflammation that's released in synovial fluid and blood. And it is supposed to have an extremely high sensitivity, both in patients with early disease and established disease. And it provides about a 15% incremental benefit in the diagnostic sensitivity of the markers for rheumatoid and CCP. So it's not just done in isolation by itself, but you use it along rheumatoid factor and CCP. It's not that widely available because even when I talk to people in first world countries, it's not being used typically, but just something for us to know about. And then we also have to remember that our workup needs to exclude other things that may explain joint symptoms and others symptoms associated with rheumatoid. So it would be beneficial to get viral studies. Hepatitis serologies are important as they cause inflammatory arthritis. And also, if you are inclined to put your patient on an immunosuppressant like methotrexate, you do need to screen them for hepatitis B first. Thyroid function, vitamin D levels, a basic ANA. If there's any kind of, suspicious presentation, massive weight loss, think of doing a serum electrophoresis also, just so that you can rule out any lymphoproliferative, myeloproliferative looking picture. And then things like MANTOO testing done both in terms of rare causes of joint issues, as well as if we plan to put the patients on certain drugs like biologic therapies. Always remember that normal serologies do not exclude the diagnosis of rheumatoid. And likewise, a positive rheumatoid factor does not necessarily mean the patient has rheumatoid. If you are able to get synovial fluid, it can be also an important part of the puzzle, because if you can draw fluid from, say, a knee and have it sent to the lab, it can confirm that this is inflammatory, especially because we know that knee osteoarthritis can also cause effusions, usually not as dramatic. And also you have to rule out other kinds of inflammatory disease, such as crystalline disorders causing massive effusions rather. Our imaging is important. Plain x-rays of small joints, still important at the start at diagnostic level. Looking for small tissue, soft tissue, swelling, symmetric joint narrowing, periarticular osteopenia, erosion, and joint destruction. And you can also do these serially as time goes on to make sure that there's no development of any structural damage, which would warrant you to change therapy. MRI important because it has the greatest sensitivity in detecting synovitis and bone marrow changes, and it's good for complex joints, joints that you cannot examine easily, and joints that an X-ray may not be able to tell you everything that you need. Musculoskeletal ultrasound has become the big thing in rheumatology because it's good. It's a bedside test, it's quick, gives you immediate data, and it can also be used not only diagnostically, but for therapeutics if you want to do an injection and know that you're hitting the right spot. So how do we put this all together? We rely on classification criteria, not necessarily designed for diagnosis, but certainly helpful in capturing patients who are most likely to have rheumatoid. The 2010 ACR-EULAR classification criteria is what we still use. It has 4 domains in it: joint distribution, in which I look at different joints, both the number and the size of the joints, and their weighted scores. As you can see, small joints get more of a score because rheumatoid typically is a small joint disease. Serology is looked at, and if you have high positivity of both rheumatoid factor and anti-CCP, you get the highest score. If you have either or, you also get a score. Duration is important because it's a chronic disease. So symptom duration is a domain, and acute phase reactants to confirm that this is inflammatory. You can say the patient has definite rheumatoid if they have a score of 6 or greater. Please remember, though, that you may not get the answer for your patient on that first visit. And the criteria allows you to, over time, follow the patient and see if additively they do meet criteria, and you can make a more concrete diagnosis. And you may also use data from before. So if the patient brings records that shows a high titer rheumatoid, not because, or a high ESR, not because of the day that you see them, they had an ESR that was normal, doesn't mean that if everything else fits, you cannot diagnose them with the condition.
Hi, Doc. I don't know what happened, but it's like you went muted. Sorry about that. Just come back to Zoom and unmute for me. Wonderful presentation so far. Reminder though, we have 2 minutes left in your presentation.
Not sure how I got muted at all.
All right, hearing you now. Sorry about that.
All right, sure. All right. So the poor prognostic factors are high CCP, high levels of inflammation, high rheumatoid factor, radiographic damage on presentation, smoking, many swollen and tender joints on presentation, and systemic symptoms. We know we want early referral for these patients and close monitoring. Education is so important. Therapies are important in terms of pharmacotherapies, but lifestyle modifications must be addressed as well. So that, exercise, weight loss, good sleep, stress reduction. Non-pharmacologic therapy is also important, such as your physio and your OT. Vaccines are to be considered in certain populations of patients, management for osteoporosis, and looking for things like GI prophylaxis so that we don't create other morbidities in the patient. So treatment, NSAIDs early for symptom relief, but we try to minimize long-term use. Corticosteroids such as prednisone, first disease-modifying drug. For rheumatoid, the average rheumatoid patient requires 15 to 20 milligrams a day, not high dose. It's initiation of treatment to be weaned and bridge therapy for acute flares. DMARDs, or immunosuppressants, would be added in order to facilitate the weaning of the steroids. And these actually alter the course of disease, and they're slow acting, so you must initiate them as early as possible. We still continue to accept methotrexate as the anchor DMARD. We can use hydroxychloroquine in milder cases that are seronegative. And then we also have other oral DMARDs in our traditional group of leflunomide, sulfasalazine, and azathioprine. Other oral agents that have come to the market are JAK inhibitors, and tofacitinib is the one we have in Jamaica. We have our biologics, of which we have TNF inhibitors, and locally we have adalimumab, infliximab, etanercept, and golimumab. IL-6 inhibitors, such as tocilizumab, are also useful. So Actemra is what it's branded as, came to fame in COVID. And the guidelines do allow us to use tocilizumab right after methotrexate. anakinra not available here, rituximab available in Jamaica, and that one blocks B cells, right? And then we have also others that block T cell co-stimulatory, and abatacept is the drug there, not available to us. I put this here as well as this flow chart, not because I expect you to be able to see all of this, and certainly time is not going to permit, but for you to have at least the reference. If you have a desire to have a deeper knowledge as how we go through the different steps in choosing what drugs are appropriate for patients, because I know some of you will work in areas where you don't have ready access to a rheumatologist. So just make a note, take a picture, screenshot of this publication. So in the pipeline, we have researchers who are working hard to meet the unmet needs, and we have a number of drugs with some really novel mechanisms of action. We have some people looking at the Indian red scorpion, venom, ibuprofen, and what this does is block potassium channels and prevent activation of certain immune cells. We have a localized kind of gene therapy they're looking at that you'd inject intra-articular. So with all these drugs we've been having in the past years, it's been systemic approach. This interferon beta drug is looking at addressing single joints. And then we are looking at also other protein kinases apart from JAK kinase, which also play a role in the pro-inflammatory state of the body associated with rheumatoid. So we have a lot to look forward to. Everybody always asks about dietary guidelines. Finally, there were published guidelines in 2022. First publication, very basic, sum it up as Mediterranean diet. So olive oil, veggies, fruits, whole grains. Be careful in your patients who have gluten sensitivity, which would not be everyone, but fish and red wine. Moderate use of dairy is allowed. So we look forward to more detailed guidelines coming out in the future. So back to my patient, Cece. The question still is, did we fail her? Are we making the best use of our specialty physicians and the therapeutic resources we do have available? Our pharmacy partners do try to help. These drugs are expensive, but they've come up with certain patient assistance programs. And so there are different people trying to help our patients get access. And we need to ask ourselves as a medical community, what are our hesitations in preventing a proactive approach, use of agents, and how do we help our patients understand the importance of compliance? Because we see so many people suffering who don't need to suffer. But the good news is that we are making progress. I think I'll just skip this for the in interest of time, but thank you so much for your attention.
Thank you so much, Dr. Davis. That was certainly enlightening, a refresher and an exposure to things that are new and evolving, and we do appreciate it. I know there will be some questions for you, but we're going to ask our participants to hold these till the question and answer period after Dr. McGee presents. And for participants, please post your questions in the Q&A link at the bottom of the screen so that when the time comes, we can ask them to both Dr. McGee and Dr. Davis. So thank you very much, Dr. Davis.
My pleasure.
I'm now going to introduce to you Dr. Tanisha McGee, who is our second speaker for this session. She is a consultant physician and rheumatologist at the Cornwall Regional Hospital in Montego Bay, Jamaica, and an associate lecturer in the Department of Medicine at the University of the West Indies, Mona. Another graduate of the University of the West Indies, Mona, where she completed her MBBS in 2003 and subsequently her DM in internal medicine in 2012. Through the G. Raymond Chan Caribbean Fellowship Award, she completed her fellowship training in rheumatology in 2017 at the University of Toronto. Upon return to Jamaica, she established a weekly rheumatology clinic and inpatient consultation service at Cornwall Regional Hospital. She has a special interest in lupus and rheumatic diseases in pregnancy and has published in peer-reviewed journals, authored a book chapter, and presented at international conferences in these areas. Dr. McGee gives back to the community through the founding and convening of the Lupus Support Group Western Jamaica, which extends the reach of the Lupus Foundation of Jamaica. It is our pleasure and a privilege to have Dr. McGee with us today to speak to us about systemic lupus erythematosus. Over to you, Dr. McGee. You're still muted. You need to unmute that. Right, there you go.
Thank you so much for the introduction, Dr. Standard Golson, and thank you so much to the Caribbean Association, Caribbean College of Family Physicians, Jamaica chapter for the invitation to participate in this webinar. It's always my pleasure to share in rheumatology because there is often unmet needs in terms of understanding some of our complex diseases. And it is my pleasure to always talk on my favorite topic, lupus. So this morning, we're going to look at systemic lupus erythematosus, and we're going to go beyond the joints. So this talk is very relevant to you as family physicians because the American College of Rheumatology has stated that the role of primary care physicians involves understanding the manifestations of lupus to aid in early diagnosis, treating and monitoring patients with mild disease, recognizing warning signs to refer to a rheumatologist appropriately, and helping to monitor disease activity and treatment in patients with moderate to severe disease. To that end, I will be going through the following. We'll define SLE as best as we can, look at the epidemiology, talk a little bit about the pathogenesis, and of course, spend some time on the clinical and immunological manifestations that will help you to spot these cases and how this applies to classification criteria. We'll look at an overview of the management strategies, have a brief discussion on lupus and pregnancy, and just give you a snapshot on the therapeutic advances. Here are some key references you might want to screen grab that you can look at later at your leisure. So I'm going to start off with a case. She's a 28-year-old Afro-Caribbean woman. She's a cosmetologist, and she has no known chronic medical illnesses. She presented with a history of intermittent subjective fever and fatigue for 4 months, inflammatory joint pain for 3 months involving the fingers, wrists, and knees. And when you talk about inflammatory joint pain, it's pain that the patient describes, that they wake up in the morning and they may feel achy. And as they move around, their achiness or pain subsides, or if they're at rest throughout the day at their desk or during, work, and then they may get achy again or have pain. And then as they ambulate or become more active, the pain subsides. So that's the kind of pain history that you want to get to distinguish that from non-inflammatory joint disease like osteoarthritis. So that's what she reported for 3 months, involving the fingers, the wrists, and the knees, with swelling at the fingers and prolonged morning stiffness. So she sought medical attention because of a rash on the face, and you can see her photo with her permission. And this rash is there for about 2 weeks, and she really was concerned about the difficulty in carrying out her occupation due to worsening swelling of her hands. Her rheumatologic review was unremarkable, and as we go through, you will see all the other symptoms that we try to elicit in that rheumatologic review. And her review of systems was otherwise unremarkable. So I'm sure with your experience, as you're going through this case, you're starting to flag some clues. First, the demographics. We have a woman in the reproductive age group of Caribbean descent. We have constitutional symptoms that is prolonged, subjective fever, fatigue. We have inflammatory joint pain. We have prolonged morning stiffness. And we have a rash to the face that I'm sure that you've spotted is a malar rash. This erythema over the malar eminences, and you see that it spares the nasolabial fold. So instantly you're thinking that this is highly probably lupus. So let's define this complex disease. So it is a systemic autoimmune disease, and it has variable manifestations. In fact, it's often referred to as a disease of 1,000 faces. Any organ system can be involved in variable combinations, and the manifestations can occur in these variable combinations over variable periods of time. And the course is chronic, waxing and waning, which makes the diagnosis often a challenge. But if we were to boil it down essentially to what it involves as an autoimmune disease, what we have is loss of tolerance to self-antigens, immune activation, and this leads to the production of multiple autoantibodies, and the ensuing immune complexes that form are deposited in tissues, leading to organ damage and dysfunction. So this can happen in any organ system. The epidemiology. So the latest data published earlier this year speaks to the wide variation. It has to do with ethnicity and environmental factors across the world. But newly diagnosed population of 0.4 million people annually, women predominantly 0.34 million versus men. And it's interesting to note that the highest estimates of SLE incidence are in the USA, Poland, and Barbados, thanks to data from Dr. Cindy Flo, one of our Caribbean rheumatologists. So you see, this is very pertinent to us. And the global prevalence, 3.4 million people affected, predominantly women, 3 million versus men, 0.3 million. Again, Barbados amongst the highest in terms of prevalence. In Jamaica, we have an estimated 6,000 people affected by lupus, and that was at 2019. 80% diagnosed between the ages of 15 and 44 years of age, and the average age of diagnosis is 20 years. So this is the kind of population that you're looking out for. Of course, we know that there's pediatric lupus, which across the world is 15 to 20% of the overall numbers of patients with lupus, and we know that there's elderly onset lupus as well. But this is the age group that you really have to have your index of suspicion on. Now, it's important to note that 1 in 10 adults were diagnosed in childhood, and the peak prevalence globally is 15 to 45 years of age. The female to male ratio peaks during the childbearing years at 11 to 1, but overall, considering the other ends of the age spectrum, it's 9 to 10 to 1. Is more prevalent in our people, 2 to 4 times more prevalent in people of color. And we, in terms of minorities, that term used, lupus tends to occur much earlier, and the symptoms are worse than average with a higher mortality rate. So this is very pertinent to us. And it's interesting to know in terms of mortality, in the US, lupus actually ranks in the top 20 leading causes of death in females between 5 and 64 years of age. So this complex disease, similar to what Dr. Davis presented, has a genetic basis and an environmental component. And I'm just going to boil it down in its simplest terms. So this is an old diagram, but I like it because it just has the key elements. So we know that there's a genetic predisposition, but this genetic predisposition only accounts for about 40 to 60% of the risk of developing lupus. And genome-wide association studies have identified over 100 gene loci associated, but none of them that we can say specifically is responsible for lupus. And then there are the environmental factors. We know certainly about ultraviolet light A and B from sunlight, as well as fluorescent lamps, and how that can induce apoptosis, so increased cell death in the skin, releasing DNA, and that aggravates the immune system, provokes an immune system response. Other environmental factors include viruses like Epstein-Barr virus and other environmental exposures such as silica. And then we know of the hormonal component. We can look at the ratio, and that gives you a clue in terms of females to males. And what we understand more now, that it is a disparity between progesterone and estrogen. And hyperprolactinemia is actually also a contributing factor. And then epigenetics, Stacey mentioned epigenetics. So certainly we have information on smoking and sunlight and how it alters the gene expression, not the genetic code itself, but the gene expression. And one of the important epigenetic factors, other than that too, is to consider drugs that cause DNA hypomethylation, such as hydralazine. So all of these come together, and central to that is an immunoregulatory dysfunction, where patients with lupus, they have less active or functional regulatory cells, and more pro-inflammatory cells active. We have things like neutrophils that just tend to release more DNA in patients with lupus, various manifestations that are coming to light. And all of this leads to the production of these dysregulated self-reactive B cells. And when these complex with self-antigens, we have immune complexes, they get deposited in tissues, and then that leads to the organ damage. Now, over time, we've got to understand that the gut microbiome is important. Patients with lupus have a restricted gut microbiome and they have leaky gut, and that contributes as well. And the disparity between males and females also has to do with the X chromosome. The X chromosome actually encodes for an intracellular signaling system that actually causes increased production of cytokines in patients with lupus. And this is important to note now that we know that one particular cytokine is very important in the pathogenesis of lupus, as type 1 interferon, and it promotes the maturation of these B cells that are doing bad things. And it perpetuates the cycle of inflammation and tissue injury. So this very complex pathogenesis actually contributes to that wide variability of what we see in this disease of 1,000 faces. And so we're going to look at the clinical and the immunological manifestations and use them in the context of classification criteria to see how we all can spot lupus as early as possible. And that really is the goal in identifying our patients early, and that's where our family physicians are very important. So I'm going to start off with the joints, because this is an area that will come to your attention most frequently. 50 to 70% of patients present with musculoskeletal involvement. And as our patient, this can be quite debilitating and affect their function. And at any point in the disease course, up to 95% of patients will have joint manifestations. The most common being arthralgia and actual arthritis, most commonly involving wrists, fingers, and knees. Now, deformities can arise in patients with this entity called Jacob's arthropathy, where they don't really have radiographic erosions like in rheumatoid arthritis. But sometimes we have to remember that patients can have overlap diseases. So an overlap between lupus and rheumatoid arthritis, we call that lupus in less than 5% of patients. And then other MSK abnormalities can be contributing in our patients. For example, avascular necrosis on the background of lupus itself, antiphospholipid antibodies, and of course, steroid use. But we want to go beyond the joints, because lupus is so much more than the joints in terms of how heterogeneous it is and how our patients may present. So I love mnemonics, and I'm sure most of us will remember SOAP Brain MD. And it's still relevant, even though it's the 1997 classification criteria from the American College of Rheumatology. But I always like to start with it because it helps us to identify some of the most common manifestations that our patients will present with. So we're going to go through them. Now, this is our patient. She presented with a malar rash, which you would have picked up. You know, it can be fixed, or it's usually fixed. It can be flat, sometimes raised, and it tends to spread a nasolabial fold. It's there when the disease is active and will go away when the disease is inactive and is photosensitive. And this can be the presenting manifestation in up to 30% of patients. The skin, again, is always a great place to spot lupus. And the discoid rash may also be a presenting manifestation. And here we have erythematous raised patches tending to be, hyperkeratotic with scaling, and follicular plugging is that classical description. And when the rashes are active, they tend to be erythematous. When they're inactive, they tend to be hypopigmented. So it can be localized to the head and neck, always look in the air. Sometimes that's the only place the discoid rash is, and it can be more diffuse, involving going beyond the head and neck. And remember that also there's an entity called cutaneous lupus erythematosus, where patients only have skin involvement, and discoid lupus is the most common cutaneous lupus erythematosus manifestation. Photosensitivity can look like many things, and it's often the patients who tell us that they have this unusual reaction to the sun, and sometimes we don't actually see it ourselves. Oral and nasal ulcers tend to be painless, and we have to sort of try to figure out to differentiate it from other manifestations, including aphthous ulcers in our patients. And we spent a little bit of time on the arthritis, which tends to be non-erosive, and we can pick up swelling or effusion in the joints. And sometimes the joints may actually be painless, but the patients may just have swelling. Serositis will come to our attention. Pleuritis, patients may have pleuritic chest pain. We may pick up a rub on auscultation. Pericarditis begs more further evaluation with electrocardiogram. You may pick up a rub. Patients may give you that typical chest pain history. It's something to be aware of. And then seizures and psychosis may also be, those are the more common neurological manifestations that our patients may present with, and we have to exclude other causes of these in our patients. We always have to check the dipstick in the office, in the clinic all the time. Persistent proteinuria of greater than 500 milligrams per day or 3+ on dipstick is always a clue. Looking at the microscopy for cellular cast in the urine is very important to clue you into the presence of glomerulonephritis. Your complete blood count is important, looking for anemia and features that suggest hemolysis with reticulocytosis, leukopenia, lymphopenia, thrombocytopenia, ideally on 2 or more occasions in the absence of other causative factors. And then there are the big clues. These are the ones that are very specific for lupus. Anti-double-stranded DNA antibody positivity, over 90% specific, and very important in helping us to follow disease activity. And then there's anti-Smith antibodies. And these are less common, 20 to 30% of patients, but highly specific in lupus. And so you would pick these, or you'd pick up the anti-Smith in your extractable nuclear antigen panel. So that's a panel that lists all of your autoantibodies, anti-SCLC70, anti-SSA, SSB, that's Sjogren's syndrome A, B, anti-Jo1 antibodies, your ENA panel. Then the antiphospholipid antibodies, initially they referred only to anticardiolipin antibodies and the lupus anticoagulants. And we know that these are antibodies that target cell membranes, your antiphospholipid layers, and increase the risk of thrombosis and adverse pregnancy outcomes. Very importantly is your ANA. Now, the ANA is not specific. You can find it in normal people, healthy people, 25% of the time, and that increases with age. It can be induced by medications associated with other autoimmune diseases. Well, what it is highly sensitive. Over 98% sensitive in lupus, and ideally want to have it by immunofluorescence. So sometimes you have a patient and they're saying lupus, you have classic findings, but the ANA is negative. You want to send it to a lab that will do it by immunofluorescence. Check it maybe by ELISA, that is giving you that negative test, and the gold standard that we have access to is immunofluorescence. So that's SoapBrainMD. But over time, what we've seen is that there are other classic manifestations which are very much big clues to lupus, such as non-scarring alopecia or subacute cutaneous lupus erythematosus, as depicted in these photos. And so the classification criteria evolved, went through the 2012 Systemic Lupus International Collaborating Clinics classification criteria in 2012. So now I want to draw your attention to the 2019 European League Against Rheumatism ACR classification criteria. Now, we know that classification criteria are used to help us. They're really designed for clinical trials, for research purposes, because they want to create a homogeneous group of patients to study a drug, to study a test, so that you don't have patients with other diseases included in a trial, which will skew your results. And so we don't have diagnostic criteria for lupus, but we use this to help us. But at the end of the day, we're going to use our clinical acumen to make that assessment that this is lupus. Now, this is the first classification criteria that uses an entry criterion. So it's proposed that if the patient does not have a positive ANA, that we shouldn't really consider them to have lupus. But we know, based on what I just discussed with you about the method of doing the ANA, that patients can present with ANAs that are negative. And so we override that with our clinical acumen. So I'm just going to go through it briefly. So we have a clinical criteria. We have immunologic criteria, and ideally the patient should have at least one clinical, one immunologic. And I want to point out to you what's new, the unexplained fever, and the cutoff of 38.3 degrees Celsius. So what is important to know is that a lot of patients with lupus early in their disease only have fever, subjective fever, and sometimes they measure it objectively. And this is very important. Over 90% of patients, they will have constitutional symptoms at some point. The classification criteria also includes now your complement levels. We know a complement can be activated and reduced in patients with lupus when the disease is active. And so you see now we have domains. And how we score the domains is that we score the highest one in the domain. So our patient, on further questioning, so she had acute cutaneous lupus, that's the malar rash. She also had oral ulcers. So her score in this domain is actually 6, not 8. And so if a patient has greater than 10 or more points, they'll be considered to have lupus. And I want to point out to you the importance of having the kidney biopsy. So your patients who have greater than 500 milligrams in 24 hours should be sent for kidney biopsy. And if they have class 3 or 4 lupus nephritis, that automatically gives them 10 points and they can be classified as lupus. So this is our current classification criteria, which improves the specificity. And the goal is to pick up patients with lupus earlier. So when you think about what tests you want to send your patients for, what symptoms you're looking for, you can always pick this up and use it as your guide. Now, I just want to highlight this area of consideration that what came out, after this classification criteria. Just wanting to highlight this area. So patients who may be ANA negative, you look for other clues. We try to just keep looking when you have a high index of suspicion. You do the complements. The complements are low. You do the antiphospholipid antibodies. They may be positive. And so this is a proposed alternative entry criterion from your ANA, which sometimes may come back negative. So as we follow up our patients, we follow disease activity with the double-stranded DNA, which may be increased, not in all patients, but can be. And it also correlates with lupus nephritis activity. We look at the complements, which may be low, C3, C4, indicating lupus activity. We look at cytopenias, particularly if they were there before. And of course, we are always checking the urine for proteinuria and looking for active urinary sediment. Now you see, we don't talk much about the ESR because it doesn't correlate with disease activity and can be persistently high in some patients because of hypergammaglobulinemia, as well as the CRP. The CRP may be helpful in terms of distinguishing the age-old problem, especially in the hospital setting. Is this lupus activity or is this infection? The CRP can be very helpful in pointing to infection, except in patients who have significantly active arthritis and serositis, where it can be elevated in those patients as well. Now, I know you can't read this very well, but just to show you what we do, at each visit or at major changes with therapy, we apply the systemic lupus erythematosus disease activity index. We go through our patients looking at these manifestations and the tests, most of which I've described already for you, and come up with a score. And we can see if our patients are in remission, which is a target, which I'll come to, if they're improving, or if the patients are not doing as well as they ought to. So we have objective measures that we use. Now, this is going to be important for those in the hospital setting, certainly, but as our partners, our primary care partners, have to be aware of the more severe manifestations of lupus that are not in the classification criteria. So, just this morning, Stacey and I were talking about a patient with diffuse alveolar hemorrhage. So patients may present with worsening respiratory symptoms. We always have to think about infection first and foremost. It is a second leading cause of mortality in our patients, but you also want to think that the lung can be involved. So it can be an itis or infection. So pneumonitis, diffuse alveolar hemorrhage because of capillaritis, any organ system can present with severe disease manifestations. And we're always particularly concerned about the brain. Lupus cerebritis, and we're concerned about the kidneys, lupus nephritis. So all of these manifestations will require you to escalate the attention to the rheumatologist, send to the hospital, and just have a high index of suspicion that this could be lupus. Even the GI tract, patients can present with abdominal pain and they look like this is a surgical abdomen. It may actually be lupus mesenteric vasculitis. So just to be aware of the severe manifestations of lupus, and when in doubt, to send the patient onto the hospital to have their evaluation made. And then, of course, also to remember that not everything is lupus. So in terms of the natural history of lupus, I just want to point out that our patients are living longer. Before glucocorticoids, 1 year survival was at 50%. Since then, we're looking at 90% at 10 years. So I want to highlight the latter part of the natural history, which is that now we have to focus on comorbidities, such as infections, accelerated atherosclerosis, and malignancies. And here, you're very important in managing these comorbidities with us, the cardiovascular comorbidities, the renal comorbidities, picking them up and the complications associated with them, having an awareness of infection, and also the impact on the reproductive system for our patients. And I really want to highlight that the leading cause of death in our patients is cardiovascular disease. Our patients have a 5 to 6-fold higher cardiovascular disease risk and a 50-fold higher risk of acute myocardial infarction than the general population. And this is due to the traditional risk factors which our family physicians are excellent at managing. And then there are non-traditional manifestations that have to do with the disease itself, like antiphospholipid antibodies, the treatment, in particular corticosteroids, especially when we're using greater than 30 milligrams per day. And so it is very important to be aware of. So I'm going to give you a snapshot of the management strategies. So the treat to target approach has creeped into lupus. And so we now have a definition of remission where there is no disease activity in the absence of corticosteroids and ideally in the absence of immunosuppressants, except we keep the patients on the immunomodulatory drug hydroxychloroquine. For patients who can't attain remission, we shoot for low disease activity. And our goal is always to prevent flares, even though this disease is characterized by flares, because we know that every flare leads to damage. And so prevention of flares is very important. And then in lupus nephritis, there are specific targets like the reduction of proteinuria by 50% in 6 to 12 months. And we know that even in the best centers, that proteinuria can be existent in up to 2 years in patients who are indeed responding to therapy. So we have goals that we have in lupus. And in terms of the immunomodulatory therapies now, we have 3 approaches: hydroxychloroquine, very important, or steroids, and then the immunosuppressants, so conventional disease-modifying therapies like methotrexate, azathioprine, mycophenolate mofetil, and biologics. Now, this is a very important slide because hydroxychloroquine is the cornerstone of lupus management. Everyone with lupus should be on hydroxychloroquine unless contraindicated. Now, you know that you've seen patients who we call incomplete lupus. They don't quite have, the classification criteria defined lupus, but we know that this is lupus. So hydroxychloroquine actually delays the progression of these patients to be definitely lupus. And very importantly, it lowers the overall disease activity, reduces flare rates, it's steroid sparing, even in the patients with more severe disease. In patients who have renal disease, it will actually assist in achieving renal remission faster. We have a lower frequency of seizures and neuropsychiatric damage. Reduction of flares in pregnant women. So never stop hydroxychloroquine in your pregnant woman. It will reduce flares, and in those who are at risk for congenital heart block, particularly mothers who have the anti-Ro antibodies, it actually reduces that risk. And patients who are now clinically quiescent, they're in remission, hydroxychloroquine should be continued. Ideally, we keep it at the lowest dose when they're in remission, 200 milligrams. And that will help to prolong this period of remission. And very importantly, this drug improves survival. It modifies platelet aggregation, reducing platelet stickiness, which reduces the cardiovascular risk. It has a favorable impact on glucose profile and lipid and our lipid profile, skewing it towards less atherosclerotic, atherogenic in terms of our LDL cholesterol. So very important drug. And we dose it at 5 milligrams per kilogram actual body weight. Our patients should be referred to ophthalmologists for screening to pick up quickly the toxic retinopathy, bullseye maculopathy that can occur in these patients, which is not common at all. 7.5% in most cohorts beyond 5 years of being on the drug. I won't spend much time on this, but just to highlight, in fact, I'd like you to just grab this because oftentimes we're not sure how to use steroids in our patients with lupus and why are patients on high doses and why some are on low doses. It really depends on stratifying the disease in its severity. So in the hospital, this is where we're going to be pulsing patients. In our mild patients, most don't need steroids, but I'm going to tell you the two critical points that we use steroids. So we tell our patients that hydroxychloroquine or the other immunosuppressants, there is a lag period in terms of becoming effective. So it may be on average 6 to 8 weeks. So steroids will help the patient to improve until the medication actually becomes effective. Now, where there is active disease, we will need steroids to treat the disease flare. And for patients who have life-threatening disease, we use extremely high doses. So very high doses, this is the pulse methylprednisone that you will find in the hospital setting. But for all our patients, we want them to be off steroids. And for those who need it because of severe disease, our goal is less than or equal to 7.5 milligrams of prednisone. That is the bare minimum that we'd like our patients to be on. Now, this is just a snapshot to give you an understanding of how we treat lupus according to the 2019 EULAR recommendations. Again, we stratify the disease. Everyone goes on hydroxychloroquine. Now, for patients who have persistent disease, this is where other immunosuppressants will come in, depending on what the disease manifestation is. So for the joints, we will now add to hydroxychloroquine methotrexate. If it's serositis, we may give azathioprine or mycophenolate. For more severe disease, for the patients who have cerebritis after high dose steroids, or as we're tapering the steroids, we have to ensure they're on agents like mycophenolate, cyclophosphamide. And these are the agents that you will find in the treatment of lupus nephritis, which has a specific approach in terms of induction of remission and maintenance of remission. And so this is a general approach. Hydroxychloroquine, then we add the immunosuppressants depending on the severity. And for those with refractory disease, we may have to escalate to the biologics, including rituximab, which we have available here in Jamaica. Adjunctive management strategies, sun protection. We tell our patients, and you can help to remind them to use their sunscreens, SPF 50 or greater, vaccinations, exercise, smoking cessation, and adequate weight management, malignancy screening, dietary modification. The Mediterranean diet, again, is what is recommended in our patients, though we don't have a specific so-called lupus diet, vitamin D repletion, targeting the blood pressure, glucose, and lipid control, being aware of the increased risk of glucocorticoid-induced osteoporosis in our patients. And as I wrap up, we have patients who are predominantly in the reproductive age group. And in times gone by, patients would be discouraged from having children, but we no longer tell our patients that. What we do tell them, very importantly, is that pregnancy must be planned. I like to say to my patients, pregnancy, planning. So preconception counseling is important. And one key question we ask our patients at first contact is, do you plan to get pregnant in the next year? That's your red flag to determine what medications you can put the patient on and what contraceptive you may recommend, and also how to counsel them. So in terms of the actual process of getting ready to conceive. So the key thing is that the condition should be controlled for at least 6 months, and the patient should not be on any medications which are contraindicated, like methotrexate, mycophenolate, cyclophosphamide. And it's important to screen our patients for anti-Ro and anti-La antibodies, which increase the risk of neonatal lupus, antiphospholipid antibodies, which can be associated with small for gestational age, preterm deliveries, as well as thrombotic events in the mother herself and adverse outcomes. We have to control the comorbidities. And a very important thing to note is that it has to be a multidisciplinary team. Your maternal fetal medicine, neonatologist, and a nephrologist, if applicable, to our patients. And in wrapping up, it's important to know that we are on the cusp of new therapies, novel mechanisms, but certain drugs have been approved in the recent 2 years. In this new target, new in its class, anifrolumab to target type 1 interferon for those who are not responding to the standard of care that I just discussed with you. Voclosporin for lupus nephritis, and another drug that we already had being used for lupus nephritis as well. And exciting times. We may actually be able to shut this down if this is a possibility. This is a gene-modified cell therapy, CAR-T therapy, where we use a viral vector to induce a patient's T cells to recognize abnormal cells and eliminate those B cells, which are going to produce those bad autoantibodies that propagate the disease. So just some things to bear in mind. So our patient had a malar rash, oral ulcers, polyarthritis, photosensitivity, constitutional symptoms. Her ANA was positive, double-stranded DNA positive. Her extractable nuclear antigen panel was negative. So of course, we started hydroxychloroquine, 5 milligrams per kilogram per day, to deal with her symptoms. Prednisone tapered over 6 weeks, that should be. And of course, we discussed lifestyle modification, pregnancy planning, and in the course of her disease, her arthritis was of particular concern. So we had to add methotrexate to get that under control, along with her baseline hydroxychloroquine to effect that target of disease control, remission, or being our goal always. So some take-home points. SLE is heterogeneous in its clinical presentation, and I just want to ask you to help to encourage our patients, because they often hear about patients who die, patients who need dialysis, when we know that the spectrum of this disease is as such that there are patients who tell me that they only remember they have lupus when they have to come here or take their medications. It can be mild, as well as we know it can be life-threatening. We have to remember that now we have the treat-to-target approach in lupus. We have to remember that hydroxychloroquine is a cornerstone of treatment. Adjunctive treatments and non-pharmacological interventions are important in the holistic approach treating our patients. There are new drugs on the horizon, but it's very important that in this partnership, we focus on the comorbidities, optimizing the current therapies that we have. So compliance is very important as well. And we need your help to check on compliance and just reinforce that. And of course, that pregnancies are possible with the appropriate planning. These are the many faces of lupus. We encourage our patients to join support groups because this really does help in this disease where sometimes the patients feel isolated. And the Lupus Foundation of Jamaica, we encourage our patients to join the foundation because of the many benefits that can be had for these patients. And so thank you for your attention. This is my favorite cup, which a group of medical students gave to me. I gather that they remember that hydroxychloroquine is the cornerstone of lupus management. Thank you so much for your attention.
Thank you ever so much, Dr. McGee. That was indeed a comprehensive review. Again, giving us a glimpse of what the current status of management is. We are running behind time, so I'm going to ask Dr. McGee and Dr. Davis if they would look at the questions in the Q&A tab and type in some answers. I'll just ask one to each of you and then ask you to type in answers to the others. The first question, Dr. McGee. I would ask you, should every GP be using DMARD before a rheumatology consult? And if so, what is to be used? You want to comment on that, Dr. McGee? For
Sure.
rheumatology. Sorry, Dr. Davis, Dr. Davis.
Say that again for me, please. Should every patient?
Should every GP be using DMARD before a rheumatology consult, and what is to be used? Would you be advising us to use it, or would you be advising us to refer?
I would advise you to refer if the potential is there for the patient to get in within a reasonable time. So once again, reasonable is 3 months. If you work in an environment where you don't have access, then I would say yes, go ahead within your comfort level as a physician and prescribe a DMARD. If the patient has mild clinical disease and also has negative serologies, it would be reasonable to start with hydroxychloroquine. If you have a patient, however, who has high positive rheumatoid factor and CCP or very florid synovitis at presentation, then methotrexate would be a better choice to start the patient on. So it comes down to what's happening with the patient, the comfort of the physician, accessibility to a rheumatologist wherever you practice. And sometimes it can just be as simple as you making a phone call to one of us and getting a guidance as to, this, that, and then we take over when we can.
Thanks for that. And I would ask you to go into the Q&A and type in the answers for the other questions that were directed at you. I think there are 2 or 3 others. Dr. McGee, I'm going to ask you one from Dr. Crawford Sykes. She has non-scarring alopecia query, not scarring alopecia. Is scarring alopecia a part of discoid or cutaneous lupus?
Yes, I was actually typing an answer to her. So scarring alopecia, non-scarring alopecia was singled out as a criterion to look for. Scarring alopecia tends to occur more with the discoid lupus, and so it isn't separated by itself. But non-scarring alopecia, so it's so-called lupus hair, where the patients have diffuse thinning of the hair, especially the hairline when the lupus is active, and then when lupus is not as active, the hair tends to grow back. And so it's non-scarring alopecia specifically in the criterion, but scarring alopecia tends to occur more often, more so with the discoid lupus. And so discoid lupus would be in the criterion of chronic cutaneous lupus.
Thank you ever so much. And thanks again to both of you for excellent presentations. We really do appreciate your taking the time on a Sunday morning to be with us. So thanks again, and please do answer the others in the Q&A session.
Okay.
Now, we all know that these kinds of webinars, conferences are not possible without the support of our sponsors. And we do appreciate those sponsors who have come on board for this particular webinar. So at this point, I would like to ask one of our sponsors to make a brief presentation to us.
Hello, good day. My name is Shannon Gibson, medical representative with CareMed Limited. And today I'll be taking you through a few of our products from our analgesic portfolio. Let's get right into it. So firstly, I'd like to talk to you a little bit about dolutegravir. So dolutegravir is a triple action combination of an analgesic and anti-inflammatory medication, which is your diclofenac 50 milligrams, along with your B vitamins, in particular your vitamin B1, vitamin B6, and vitamin B12. Now, it is indicated to relieve pain and inflammation and also support nerve health. In doing that, it targets your nociceptive pain and also your neuropathic pain. So in terms of how it acts, your nociceptive pain is targeted by your diclofenac through COX and lipoxygenase inhibition. In terms of your neuropathic approach, it is targeted by your vitamin B1, vitamin B6, and your vitamin B12. to target the regeneration of damaged nerves and also offering neuroprotection. So we have two presentations of your Doloneurobion. We have the oral form, which is your Doloneurobion N, and this targets moderate pain. So you can look forward to using your Doloneurobion N for maintenance therapy of acute pain. We also have our injectable formulation, which is your Doloneurobion DC, and this targets moderate to severe pain. This is useful for intensive treatment of acute pain. So in terms of dosing, your Doloneurobion N is dosed at 1 tablet 3 times daily. In terms of your Doloneurobion DC, which is your injectable, it is dosed as 1 ampule once daily until acute symptoms subside, and then 2 to 3 ampules per week. It is also important to note that the ampule comes as a pair, with the diclofenac component being separate from the vitamin B component. Why prescribe your Doloneurobion? You're getting triple action therapy with analgesic, anti-inflammatory, and anti-neurotic support. And you're also getting significant neuroprotective effects. So let's jump into our Voltaren ML gel. Voltaren ML gel is a topical anti-inflammatory that contains your diclofenac diethylamine. The ML gel is really a mix of a gel and a cream, and what this offers is deep penetration, fast absorption, and a non-greasy feel, and it is targeted to whatever area that the patient is feeling pain. Now you're getting a triple effect with your Voltaren gel, where it relieves pain, improves mobility, and also reduces stiffness. In terms of method of use, you apply it by massaging it lightly into the area 3 to 4 times daily. Also reminding you that we have 3 convenient sizes. We have a 20 gram, 50 gram, and 100 gram presentation. And so there's a size for everyone. Moving into our Cetadine. Cetadine is our acetaminophen and codeine combination that offers experienced, effective pain relief. Now, this is through FP, so it's made locally here in Jamaica and it's one of our home brands. Cetadine contains 500 milligrams of acetaminophen along with 8 milligrams of codeine, and Cetadine F, which is pretty new to the market, contains 500 milligrams of acetaminophen and 30 milligrams of codeine. So in terms of dosage, your usual dosage for adults is 1 to 2 tablets 3 to 4 times daily for both their Cetadine and Cetadine F. And in terms of its indications, you can consider it for migraines, musculoskeletal pain, toothaches, dysmenorrhea. And that's it for our spotlight on a few of the products that we have here at CaraMed from our analgesic portfolio. Thank you so much for your attention, and remember that all of these products discussed here today are distributed by CaraMed Limited. Take care.
Good day, everyone. I am Paulette Bedward, the representative from Medimpex Jamaica.
Sorry, Mr. Heron, are we having another one right now, or just CaraMed?
There's another one from Medimpex as well.
Okay.
Okay.
Good day, everyone. I am Paulette Bedward, the representative from Medimpex Jamaica Limited, and I'll be presenting on a few products during the sponsor spotlight. First up is our Melaflam, the non-steroidal anti-inflammatory drug with relative COX-2 selectivity. It's available as a 15 milligram tablet, and the active ingredient meloxicam. The tablets are scored, which allows for a 7.5 milligram dosing as well. Meloxicam acts by inhibiting the cyclooxygenase, the enzyme responsible for converting arachidonic acid into prostaglandin, which are the mediators of inflammation. Indications and dosage of melaflam. For the exacerbation of osteoarthritis, the dose of melaflam is 7.5 milligram daily, increased to 50 milligrams daily. So that's half tablet increased to a maximum of 1 tablet daily. For rheumatoid arthritis and ankylosing spondylitis, it's melaflam 15 milligrams, that's 1 tablet once a day, and may be reduced to half tablet or 7.5 milligram based on the therapeutic response. And the maximum daily dose is 15 milligrams daily with meals. Contraindications. Severe heart failure, active GI ulceration or history of recurrent peptic ulcer, history of GI bleeding or perforation related to previous NSAID therapy, severe hepatic impairment, severe non-dialyzed renal failure, pregnancy, and lactation. Side effects, the most common side effects are those related to the GI. Example, GI bleeding, ulceration or perforation, dyspepsia, nausea and vomiting, abdominal pain, constipation, flatulence, and diarrhea. What's the price of our melaflam? It's 15 milligram, which is the only strength that we have available. And if I just to highlight, the tablets are scored. The price without NHF, it's $23 per tab, and NHF fully subsidized the melaflam. The patient only will have a prescription fee to pay. And the prescription fee is less than $300. And that's for a full 28-day tablet, a full month supply. Next up is our Sorbifol. And our Sorbifol is our slow-release iron tablets. The iron is embedded in a spongoid matrix and is released gradually over 6 to 8 hours. At the end of this period, the structure that remains is excreted from the body. This comfort dosing allows for fewer side effects profile, and the tablets also contain 60 milligram of vitamin C or ascorbic acid that aids in the absorption of the iron. As mentioned, it contains 60 milligram of vitamin C, and the tablet contains 100 milligram of elemental iron. It's 320 milligram ferrous sulfate, 100 milligram elemental iron. It's slow release technology and it's very affordable, only $31 per tab, and it's available over the counter. Indications: prophylactic treatment of iron deficiency, therapy for latent and manifest iron deficiency. What's the dosage? Average dose for children over 12 years and older, adults and children over 12 years. It's 1 tablet 2 times daily, at least 30 minutes before meals. It can also be dosed once daily if the anemia is mild. In pregnancy, during the first 6 months, it's 1 tablet once daily. In the last trimester and during the periods of nursing, it's 1 tablet 2 times daily. That's the recommended dosage. Why Sorbifol? Gradual but even release of the active ingredient, that's the 100 milligram of elemental iron, over a 6 to 8 hours time period. And this facilitates comfort dosing, less chance of GI constipation or GI irritation due to the slow release of the ingredients, fast absorption of the iron due to the presence of the vitamin C. It's a very small odorless tablet and it's very affordable. Next up is our Curiosin, and this is one of my favorite products to detail because the benefits are visible. You see it happening right before your eyes. All right, so Curiosin is our wound care product. It contains hyaluronic acid, which is the active ingredient. Curiosin is a wound care preparation designed for quality wound healing. It's a clear, non-irritant, highly biocompatible product supplied as a gel for the management of various types of wounds. How does it work? It provides a moist environment necessary to facilitate physiological wound healing. The viscoelastic matrix form facilitates granulation and epithelialization and protects the cells against, it also protects the cells against free radicals, resulting in reduced tissue inflammation and controls wound pain. Indications: management of chronic wounds of different origin, such as the venous leg ulcer, the diabetic foot, arterial leg ulcer, and the decubitus sores. It's also used for the management of minor injuries, household injuries, lacerations, burns, both first and second degree. What is recommended dosage and how to apply? First, clean the wound, complete debridement if necessary by gently rinsing with 3% hydrogen peroxide or saline. During wound healing, the affected area can become overrun with necrotic or dead tissues, and this can be harmful to the body's ability to recover and develop new skin. So debridement is necessary in preparing the wound bed to promote speedy and efficient healing. Curiosin creates a moist environment that enhances the body's natural ability to shed off dead. Okay, so after cleaning, you apply the Curiosin. Only a 1 millimeter film is necessary, and you apply that around the wound. It's viscoelastic in nature, so it will spread. Covering is optional. You may choose to cover or leave open. NHF coverage. The NHF covers Curiosin under vascular disorders and diabetes. If the condition is indicated as moderate, the patient will receive 1 tube per month. If it's severe, it's 2 tubes per month. And the patient pays roughly $1,100 per tube after the NHF subsidy. And as I said, with Curiosin is one of my favorite products to highlight because you're seeing the transformation with the patient. So I've included a few pictures from research that were conducted on the Curiosin. And here we have a patient, 47 years old, that suffered with diabetes for 13 years, also for 6 months, and complete wound healing here of their also in just 11 weeks, and the dosing for Curiosin was used once daily on this wound. Here we have another patient. Picture 1 shows before, picture 2 shows day 12 of treatment and complete healing in just 27 days. Here we have another patient. On the left, sacral pressure sore is a female, 38 years old, and on the right, complete epithelialization after 2 months of treatment of this bed sore. Venous leg also. The leg also persisting for 20 years in this female patient who is 60 years old, and nearly complete healing after 9 months of treatment. So unfortunately, time does not heal all wounds, so we definitely need you to help close the wound with Curiosin. Okay, and next up, our Midocalm. And the Midocalm contains the active ingredient tolperazone, 150 milligram, and the dosing it's 1 to 2 tablets 3 times daily. Maximum is 2 tablets 3 times daily. That's 300 milligram of the tolperazone 3 times daily. Midocalm works by blocking the sodium channel in the sodium-potassium pump in the neuron cell membrane, and this prevents an action potential from being created, and therefore the signal transmission is stopped. Side effects are listed here. Drug interactions, no drug interactions have been observed. Combines well with the benzodiazepines and NSAIDs. Contraindications, myasthenia gravis, or any condition causing rapid exhaustion of the musculature, and persons with hypersensitivity to the drug. And last but not least, our Amlator. Amlator is the newest addition to the Medimpex portfolio, and it contains 2 active ingredients, amlodipine and atorvastatin, and the name is an acronym of the 2 drugs that it contains. We have it available as 3 strengths, Amlator 510, Amlator 520, and Amlator 1020. The cost of the Amlator, very, very affordable. It's one of those drugs that is fully covered by the National Health Fund. And in the case of the 520 and the 1020, the coverage is actually more than the cost of the drug, and the patient just pays a prescription fee. and the prescription fee is less than $200 in this case. For the 510 for a full month supply, the patient pays $120. And this I'm talking about 30 tablets of any one of these strengths, less than $200 cost to the patient. So for those patients with hyperlipidemia and hypertension, remember ambulatory combinations. And thank you for your attention. Thank you. Drugs highlighted, Melaflam, Sorbiflor, Curiosin, Amlator, and Midacam. It was my pleasure being here with you. Have a wonderful rest of the day.
Thank you very much. And our sincere thanks to both CariMed and Medimplex for their continued support of CCFP Jamaica chapter events, not only today, but over the years. At this point, I will hand over to the moderator for the second session, Dr. Pauline Williams-Green, and thank you for your attention during session 1. Dr. Pauline.
Thank you so much, Dr. Samuel Gosen, for carrying us through the first round. Wow, what a session. Awesome. Very fulfilling, very helpful. But we're going to roll along now with Dr. Anishka Roll, who is a consultant and the director of infusion services at Doctors Hospital and the Bahamas Health and Healing Medical Center in the Bahamas. So welcome from the Bahamas, Dr. Rowe.
Thank you.
She earned her medical degree from the University of the West Indies and completed internal medicine residency and rheumatology fellowship training at Carrie Lyon Clinic and Roger Williams Medical Center at Brown University, respectively. She's a fellow of the American College of Rheumatology and has ACR certification in musculoskeletal ultrasonography. She's also the vice president of the Caribbean Association for Rheumatology and a member of the Association for Women in Rheumatology. She is an advocate for promoting community awareness of chronic rheumatic diseases with special emphasis on lupus through the Bahamas Lupus 242 Foundation. And of course, supporting the expansion of National Drug Plan. However, today she talks to us about psoriatic arthritis, and this is such an important topic. We see it in practice, but don't hear enough of it. Dr. Rowe, please take it away.
Good afternoon, everybody. Thank you so much for having me. I am going to try to share my screen now, and please let me know if you can see anything.
Not seen anything yet. Oh, here it comes.
One second. Does that work?
There it is.
Okay, great. Thanks for having me, everybody. As previously stated, my name is Dr. Roll, and I'm a community rheumatologist in Nassau, Bahamas. I am happy to share with you today some thoughts on psoriatic arthritis, and so I hope to get some engaging discussion at the end. I have no financial disclosures. I have few learning objectives, and just give me 1 second here. I'm going to minimize this. This is to summarize the current understanding of the pathogenesis of psoriatic arthritis and extra-articular manifestations, to review the clinical features of psoriatic arthritis, to develop a clinical approach to the evaluation and management of those patients with psoriatic arthritis, and finally, to highlight the latest cytokine-targeted treatment options. I wanted to start with a familiar case scenario so that you can get an understanding of some of the type of patients we see, sometimes mild, but sometimes with significant complex comorbidities. So I start with a 67-year-old female, SW, who has a 15-year history of pain in multiple joints of a symmetric and migratory pattern, as well as chronic low back pain associated with morning stiffness for about 2 hours. The pain, stiffness, and swelling started in her ankles initially, followed by elbows, shoulders, her wrists, and then ultimately involved her small joints of her hands and her feet. She did not report any skin lesions but had nail discoloration and thickening for more than 10 years. She gave us a family history of her father having a desquamative lesions all over, as well as a spinal condition that left him bedridden. She also has a daughter with a recent diagnosis of scalp psoriasis. So Ms. SW was ultimately diagnosed with rheumatoid arthritis and had been treated subsequently with multiple NSAIDs for her joint pains, along with DMARDs, hydroxychloroquine, and methotrexate, which unfortunately she wasn't taking regularly and had no significant response. Her clinical examination, when seeing this patient, she was in a wheelchair, so unable to walk with stable vital signs. She had 22 tender and swollen joint counts involving her shoulders, her elbows, her hand joints, hips, knees, and feet. In her hands, her metacarpal phalangeal proximal and distal interphalangeal joints showed hypermobility, telescoping of her fingers with tenderness and chronic synovitis of most joints. She also had limited arm raising, pain in both shoulders, and elbows with contraction at 20 degrees of flexion. Her hips had very limited mobility, and she was unable to get out of her wheelchair unassisted. She had tenderness in her knees and mild swelling and pain and swelling in her ankles. She showed dactylitis in the second toe of her right foot. And on assessing her spine, it was severely restricted in all range of motions, particularly at the neck. She had bilateral cervical rotation of only 30 degrees, and she could not extend or flex her head. She had no skin lesions or rash, but her nails on both hands and feet showed some onycholysis, hyperkeratosis, leukonychia, and crumbling, as well as discoloration, and the rest of her systemic review was completely normal. So in a diagnostic workup, we did labs, of course, and x-rays, and her baseline lab showed that she had a normocytic normochromic anemia, along with chemistries that were perfectly normal, that being renal and liver profile. She had an elevated sedimentation rate of 40 and an elevated CRP of 39. She was RF, or rheumatoid factor, and anticyclic citrullonated peptide negative. Her hand x-rays, as you can see here, show significant loss of all the carpal bones. There's significant diffuse osteopenia. There are areas of complete subluxation in her MCPs and PIP joints. There's some early pencil and cup deformity starting, and she has osteitis around both periarticular and along the shaft of her joints. She also did some pelvic x-rays, and they showed bilateral sacroiliitis. So what is psoriatic arthritis? We know that it is a chronic inflammatory arthritis that is progressive and is associated with psoriasis. If left untreated, like rheumatoid arthritis and some of the other discussions that you have already heard from today, it can lead to long-term adverse outcomes like deformity and in some persons, even death. It belongs to a family of the spondyloarthropathies or spondyloarthritis, where the musculoskeletal manifestations include not just a peripheral arthritis, like you would see in rheumatoid arthritis or gout, but also dactylitis, which is inflammation, pain, swelling of the entire digit, enthesitis, where tendons are attached onto the bones like the elbows and the Achilles, and also axial arthropathy involving the spine from the cervical to the lumbosacral areas. Approximately 15% of people with psoriasis develop psoriatic attacks, develop psoriatic arthritis. At times, though, the arthritis can precede the onset of the skin disorder, which makes it, of course, more difficult to diagnose. And this sometimes occurs in about 20% of the cases. It appears in people between the ages of 30 to 50, but can begin as early as childhood. And we know that men and women are of equal risk. So looking at a PROSPER study, which included about 18 countries and from Latin America and the Caribbean, the cases of psoriatic arthritis were estimated to be 1.2 per 100,000 person years. However, it affects globally 1% of the population, and in the US, about 1.5 million people. So the pathogenesis, where does this disease come from? There are many factors. Like most autoimmune connective tissue disease, we have environmental triggers, whether that be bacterial or viral infections, from physical trauma, from oxidative stress issues like smoking. And then there's the genetic predisposition, including mitochondrial DNA mutations. These leads to oxidative stress, which leads to mitochondrial dysfunction, and ultimately propagation of innate and acquired immunity, where you have influx of macrophage and dendritic cells, leading to the proliferation of cytokines. In particular, I'll mention interleukin 12, 23, interleukin 17, TNF alpha. There's also B cells and its aggregates like CD4 and CD8 T cells as well. And these ultimately lead to the clinical manifestations that we know represents psoriatic arthritis, which includes erosions, excessive bone formation or ossification, synovitis, enthesitis, and tendinitis. So this is a very busy schema, sorry about that. But what I wanted to do was show you some of the pathogenesis that I just explained, trickling down to the clinical manifestations. So one includes HLA-B27 positivity in many patients. Again, having that negative does not mean that you cannot have psoriatic arthritis or spondyloarthritis. Having a positive family history of psoriasis, and sometimes T-cell activation of unknown mechanism. This leads to infiltration again of the joint with T and B cells, natural killer cells, and macrophages, which leads to this profuse increased production of inflammatory molecules like TNF alpha, interleukins, and then this has a systemic effect throughout the body. On the tendons and connective tissues, there's inflammation of the entheses and connective tissue causing swelling, dactylitis, enthesitis. In the skin, the immune reaction leads to destruction of the nails, leading to many different forms of psoriasis, psoriatic plaque, skin nail pitting, ridging, and hyperkeratosis. In the joints, leads to angiogenesis and vasculitic changes in the blood vessel, a stimulation of inflammatory cytokines, and increased osteoclastic activity, which ultimately leads to mainly an asymmetric oligoarthritis, an arthritis involving the predilection for the distal interphalangeal joints. In some cases, however, and that could be as high as 15 to 20% of patients, they can present with a symmetric polyarthritis, mimicking that of rheumatoid arthritis. And what is different from rheumatoid arthritis, and I just want to make this clear, is axial involvement, which does not occur in any significant manifestation, except spine involvement in some rheumatoid patients that have long-standing disease. Axial involvement involves both the C, T, and L spine, and involvement of the sacroiliac joints, and in some cases in which you have severe aggressive disease, arthritis mutilans. In terms of the X-ray, what do we find? And I'll go over some of these things. We find periostitis, syndesmophytes, erosions, pendulum cup deformities like our patient SW before, osteolysis, and even ankylosis of the joints. So we know psoriatic arthritis is a multifaceted disease. Like I just mentioned, we have skin, joint features, and ocular involvement in psoriatic arthritis. In imaging, we have very specific features on X-rays, whether that be of the pelvis with the sacroiliitis or the L and C spine with the syndesmophytes, and peripheral arthritis, where there are very specific features that I'll go through in more detail. In terms of our labs, we look for features that will rule out other types of inflammatory arthritis, that being connective tissue diseases or rheumatoid arthritis that Dr. Davis already expanded upon. And in terms of comorbidities, this is very important as a part of the full spectrum of controlling patients and managing them with psoriatic arthritis. These patients are at risk for a plethora of non-communicable chronic diseases like diabetes, hypertension, obesity, etc. So part of the diagnosis, we use a classification criteria, which is simple to use, and you can use it in clinical practice. Sometimes we do need to employ this definitely because not all cases are clear cut. So diagnosis, we have, it's an inflammatory articular disease, can involve both the peripheral joints and the spine or any end pieces. We know that we need to have imaging done and we need labs to support an active inflammatory disease. And so that means checking the SET rate, the CRP, ruling out rheumatoid arthritis and other connective tissue diseases that might have similar features if the case is not clear cut. So in the CASPAR criteria, you need equal or 3 points in this chart that I have outlined here. And so that includes, you do not have to have active psoriasis, but if you do, you have 2 points. You can have a personal history of prior psoriasis, whether that be in childhood or adolescence, or family history of psoriasis, and you get 1 point. Psoriatic nail dystrophy is also included with 1 point with pitting, onycholysis, and hyperkeratosis, and 1 point for a negative rheumatoid factor. There is also 1 point for current swelling of the entire digit, which is a definition of dactylitis or history of dactylitis, and 1 point of radiographic evidence of either new bone formation, ill-defined ossification, or osteolytis near the joint margins on plain x-rays of the hands and foot. And so going through these criteria, you can see that our patient definitely meets that diagnosis. Clinical manifestations, again, psoriasis, distal arthritis, meaning involving the DIP or distal interphalangeal joints, asymmetric oligoarthritis. And what do I mean by that? Having less than 5 small or large joints affected in an asymmetric distribution, meaning it could be your elbow, it could be the hands, it could be the knees, etc. But there are cases where there are some symmetric polyarthritis and arthritis mutilans, and then a spondyloarthritis, different from what we will see in other cases of seronegative spondyloarthropathy or axial SpA. And 30% to 50% of psoriatic arthritis patients can have enthesitis, particularly at the Achilles tendon and the plantar fascia. So this is a very important point that I want to highlight, because there are patients who might not present with florid psoriasis or even specific florid peripheral inflammatory arthritis involving their small hands or feet, but they might come to you with a swollen Achilles or plantar fasciitis symptoms with difficulty getting out of bed and having exquisite pain on walking in the morning. And these are some clear signs that you need to maybe look further if this is something that is persistent or if there's something that frequently occurs. There's also tendinitis, tenosynovitis, and dactylitis, some of the very main features that we have to see. And what I want to mention, particularly looking at this case, I'll put it there, is you can see that this toe is very swollen, it's fat. So that's what we look at in dactylitis. It's not very obvious, but these are things, are clues that you have to look for. Again, the psoriasis might not be something that is very obvious, but sometimes we have to address the patient and take a good look at all those places that they might not have mentioned or might not look so obvious, like, for example, the periumbilical area or the posterior auricular area behind the ears, or even the scalp, asking them about if they have a flaking or scabs in their head, and different things in terms of what they use for their shampoos, etc. That might give us a clinical clue as to, does this patient actually have psoriasis and subsequently psoriatic arthritis? So I want to move on to the radiographic changes in the cause of psoriasis. And first, we'll talk about the peripheral arthritis. What we look for in the peripheral arthritis is fluffy periostitis. What is that? It's like whittling of the bone around areas of the digits. And you can see different changes in it. It almost looks like there's a halo somewhat around the bone. We also look for joint space narrowing, and particularly, like I said, a predilection for the DIP and the PIP joints. And we look for, this is when patients have significant severe deformity, things like subluxation, as in these cases here, and or pencil and cup deformity, where you have whittling of this part of the digit and formation of, and this is all because of osteolysis at that joint. So looking at other features, you know, in part of rheumatology, and many persons like yourself in family medicine might also use ultrasound imaging, MRI, to further elucidate things that we can't find on imaging. So this is an ultrasound showing the flexor tendon here in the second digit of the hand. And what it's showing is edema, and the T1 or stir weighted images are showing a hyperintense signal around the tendon, which suggests that there's inflammation. On ultrasound images, both longitudinal and axial views, what you can see is a hypo echogenicity around the area of the flexor tendon. But in these areas where Doppler signal is, both on longitudinal and axial view, there is hypervascularity, which suggests that there's inflammation as well around the tendon and the joint. Looking at the heel and the Achilles, what we see on X-ray is significant calcifications above. This is on transverse view of the Achilles that is not attached to the bone. And so when we look at lateral imaging here, it shows that, you know, there's inflammation, some edema in Koffer's pad here, and there's also areas of this bright signal here, hyperechogenicity in extending into the Achilles tendon where it inserts onto the Achilles. Looking again with Doppler signal, we see hypervascularity inside the tendon as well, suggesting that there's inflammation and edema. So these are some of the images that we can see quite often in patients that have axial involvement, whether it be the C-spine or the lumbar spine. So we're looking for features different from just degenerative arthritis, and there are some features that overlap with things like spondyloarthropathies, like for example, AS or ankylosing spondylitis. And so it might be at times difficult to differentiate, but given the clinical clues in terms of what the patient comes with, and we look at other things like the pelvis, then we come to a conclusion as to what this patient might have. In this case, we see here there's narrowing of the disc spaces, there's significant in bony enlargement here, as well as in desmophytes that are bridging. We also see large bone spurs here, or osteophytes coming off of the spine, all very significant features consistent with psoriatic arthritis. And sometimes there's even complete fusion or ankylosis of the vertebra that can occur both in the spine, which leads to obviously reduced mobility in the spine, and or rigidity that makes the person, you know, unable to do routine tasks. And this is part of accruing damage, which leads to increased morbidity in our patients. So again, looking at radiographic and MRI images, what I wanted to talk about specifically is who mainly gets axial psoriatic arthritis. And so usually it's patients who are older in onset, which again is opposite to patients with ankylosing spondylitis, usually starting in younger age, people in teenagers. Male to female incidence is equal, and we see that in ankylosing spondylitis, we have a predilection mainly for younger males. In terms of genetics, there is HLA-B27 positivity associated with it, but there's also a high association with HLA-B08 and HLA-B38. Clinically, there's mainly a lack of inflammatory back symptoms. There's not as frequent as an ankylosing spondylitis, and so this can be tricky. And these patients just may be, you might be misled to think that they just have mechanical back disease. In terms of if the cervical spine is involved in most commonly, and you have fusion of the facet joints, frequently you have asymmetric, less severe sacroiliitis as opposed to ankylosing spondylitis, and you have non-marginal syndesmophytes and paravertebral ossifications. I just want to highlight here that when we do ask for an MRI, we want to ask for both parallel and perpendicular views of the sacroiliac joints. And we know that we're looking at both STIR and gadolinium enhanced T1 weighted images. And what we're looking at is we're looking for subcondylar and periarticular sclerosis. We're also looking for hyperintense lesions, meaning those areas that look white, both on STIR images for erosions and for sclerosis, hypointense on T1 weighted images. How do we treat these patients? And I'll get into that more significantly later on, but the treatment includes NSAIDs. It also includes biologic therapy, TNF inhibitors, but what it doesn't include for patients, particularly with primary axial disease, is DMARD therapy. So I'll expand on that later. So what I want to talk about now in the second part is our extra-articular manifestations of psoriatic arthritis. And there are many that we miss, but as we try to treat the entire patient, we have to take into consideration all the other things that affect their overall health. And that includes obesity, cardiovascular disease, diabetes, having osteoporosis or bone loss, risk of inflammatory bowel disease, and also inflammatory eye disease, particularly uveitis. So when we do psoriasis and psoriatic arthritis comorbidity screening, there's some simple things that you can do like you normally do with any other patient, looking at their weight and height, calculating their BMI, looking at their blood pressure, and trying to manage that, suggesting ways in which diet, exercise, and of course, medications can increase and improve the management of these patients the patient's overall health. We also want to get routine blood tests, of course, apart from the baseline liver and kidney function. We want to check their cholesterol and glucose levels and HbA1c to look at their risk for diabetes as well, because these things, all of them should be managed in addition to their psoriasis and their psoriatic arthritis. And this is where it's very important to get the primary care doctors, general physicians, primary care physicians, family physicians, and anybody else involved in taking care, because we have to have a multidisciplinary team approach. So looking at the prevalence of comorbidities in these patients, we see that hypertension, diabetes, metabolic syndrome, all of these things put these patients at increased risk. And patients are at increased risk, in patients with psoriatic arthritis. And so again, these are very important things to address to control the disease and to control the entire clinical outcome for the patient. So what I want to talk about specifically, and what many people forget in psoriatic arthritis, is its affiliations with two very important disease outcomes, and that includes inflammatory bowel disease in psoriatic arthritis and ocular disease. Now, there has been more recent knowledge of the gut joint axis, and this is because of the shared lymphoid and T cells that make interleukin 23 and interleukin 17 and gut alteration in the microbiome. And as I mentioned, those are the same cytokines that stimulate psoriasis and the psoriatic arthritis and the long-term chronic inflammatory arthritis that these patients experience. So patients with psoriasis and psoriatic arthritis have a 1 to 4-fold increased risk of inflammatory bowel disease compared to the general population. And so I'm saying this because that means then that we need to take an extra effort, doctors, to screen these patients for inflammatory bowel disease, meaning let them make sure they're getting their colonoscopies, etc. If the patient has active issues with the bowel, going a step further and letting them see the gastroenterologist if feasible. There is 30 to 42% and endoscopic or macroscopic evidence of GI inflammation in these patients, and 46 to 58% have histologic or microscopic inflammation. And so the more severe the psoriatic arthritis, particularly in those patients with axial psoriatic arthritis, the more common we see inflammatory bowel disease. So another very important feature is ocular disease in psoriatic arthritis. For some people, they are not aware that the eyes can be involved in some of our diseases. And this is a very important point. And this is because this would give you the clinical, heightened awareness that in these patients, they should have routine slit lamp examinations and to see if any inflammation is going on in the eye, even without active symptoms. Now, ocular disease is associated with strong HLA-B27 association. And again, here comes those cytokines and those specific cells, TH1 helper and 17 and TNF alpha, interleukin 17 and 23 again, that's involved in ocular inflammation. The most common ocular inflammation is acute anterior uveitis with a prevalence of 20.
Hello, Doc, I think we lost the audio. Can you unmute for me, please?
Hi, someone muted me. Can you hear me?
Sorry. Yeah, you're back. Just a reminder, you have 2 minutes left.
Okay. Acute anterior uveitis, and the most common signs and symptoms are pain and photophobia in these patients, and it's usually bilateral, chronic, and severe. We treat these patients who have this persistent recurrent disease, again, with biologic therapy. Hi, can you all see the screen move? I don't know, it's not moving. Hello?
Has not moved. You're correct.
I don't
Mr.
know.
Heron?
Maybe someone else took over the screen. I am not able to move it. Hello?
Sam, can you hear us?
I can hear you.
Yes, I can hear you, Anishka. It's Sam to help us with moving the screen.
Someone took, I can't control the screen. I don't know why.
Control isn't gone. Can you just click on the PowerPoint?
I am. And it wasn't moving. That's what I'm saying. So in the case scenario, psoriatic arthritis Butylenz is a diagnosis for our patient. She met the criteria with 5 points. Like I had already mentioned before, the fact that she had the family history, the fact that she had nail involvement, the fact that she had arthritis changes, negative rheumatoid factor. Multidisciplinary team approach for this patient who by now needs orthopedics to get involved as well because of her significant deformities. Medications for her, like I had mentioned, she had not been using methotrexate on a regular basis, but we did attempt to put her back on that antibiologic, which is a TNF inhibitor, adalimumab, and she failed that, but subsequently we put her on secukinumab and she did really well with less than 3 tender and swollen joints to date. And she's actually with therapy has had significant improvement in terms of her gait and balance training. So this brings me now to my treatment. There are many non-pharmacologic options with physical therapy, occupational therapy, and the like. Then, of course, we all aware of this NSAIDs, but for cases of more aggressive, when we talk about moderate to severe disease, this is where we want to start our oral small molecules like methotrexate, sulfasalazine, and in some people, even cyclosporin and leflunomide. But more commonly, we move to TNF inhibitors. And ultimately, when those don't work or the patient has not responded as well, we move up to the interleukin 12, 23 inhibitors, interleukin 17 inhibitors, and even JAK inhibitors, depending on the response. This is a very broad schemata, but what I want to point out is that with axial disease, we jump directly to biologics. And in some times we can use small molecules like JAK inhibitors. For peripheral symptoms, we use our mainstay drug is methotrexate, and we use that with biologics mainly. But there are cases where there is no difference in terms of efficacy or outcome with use of methotrexate in some patients. And so sometimes we use just the biologics alone. For patients presenting with enthesitis in particular, we move directly to biologics like TNF inhibitors, interleukin-17, interleukin-21, 12, and 23 inhibitors, because these patients will have, like the patients with axial involvement, very minimal response to DMARDs. So how do we measure our response? We look at something called a minimal disease criteria, the Leeds Minimal Disease Activity Score, and we score patients based on tender, swollen joints, the total body surface area involved. And so this is a useful tool that you can use in your practice to help you determine if the patient is actually responding to the medications. Finally, managing psoriatic beyond our medications, like I mentioned, again, a team approach. We need to have patients exercising, get them involved in physical therapy when indicated, implement occupational therapy, even complementary therapy like acupuncture and massage when necessary. And then there are some natural and holistic things that we can use, because I know our cultural and our patient population like us to give recommendation on things that will reduce inflammation like turmeric and apple cider vinegar, aloe vera. Healthy diet is always important. And for patients that suffer from depression in particular, to reduce stress and seek out psychotherapy. So in summary, what I want you to remember is that it's a multidisciplinary team approach. Early diagnosis and treatment is very important, and we treat to target. We try to get patient at low disease activity, if not remission. We try to monitor and address our comorbidities, particularly risk for metabolic syndrome, hypertension, diabetes, and that means lifestyle modification, smoking cessation, weight reduction, physical therapy, and low impact exercise. Thank you so much for your attention.
Thank you so much, Dr. Roll. I just think you rolled along excellently. Very interesting topic, a great highlight, a lot of learning from me, quite enlightening. And I'm sure the questions are going to come fast and furious. And we're pretty much just within our timeline. Do we have a sponsor now, Sam, or do we go on to our next speaker?
Sure, so we have two sponsors, Paul Russell from Abbott, and then we have Amoy Rickman from H2K.
All right, please go ahead, Paul.
Okay, are you seeing my screen with the Abbott A?
No, just seeing you with the wonderful headphones.
All right, let me see if I can share my screen.
No problem.
Okay, start. You seen the A now?
Yes, sir.
Okay. All right. Good afternoon. My name is Paul Russell from Abbott Nutrition, and I want to thank CCFPJ for the opportunity to present on a few of our nutritional products. But first, I want to mention that Abbott products cover various stages of life, from infants through to the aging, and also for patients with special health needs. So let's first look on Ensure Complete, which is an all-in-one premium nutrition blend supporting muscle, bone, immune, heart, and digestive health. It's formulated to help maintain and regain lean body mass and strength in patients recovering from injury, illness, and surgery. It provides 30 grams of high-quality protein. It has an excellent source of calcium and vitamin D to support bone health. It's an excellent source of plant-based omega-3 fatty acids, ALA, to support heart health. And it's an excellent source of antioxidants, vitamin C, vitamin E, and selenium to support immune health. It's a good source of fiber also to support digestive health. It's calorically dense with 350 calories in 10 fluid ounces, and it comes in assorted flavors. A similar product with 30 grams of protein is Ensure Max Protein. And Ensure Max Protein is a high protein, low fat nutrition shake with 1 gram of sugar for person extra protein. It's also 150 calories and has 2 grams of dietary fiber. Now, both Ensure presentations, Ensure Complete and Ensure Max Protein, are kosher and halal prepared. They're gluten-free and they're suitable for lactose intolerance. So with 6 Ensure presentations available in the Jamaican market, there is an Ensure to help your patients reach their nutritional goals. For the persons who are living with diabetes, let me suggest Glucerna Hunger Smart. It's a delicious meal or a snack replacement designed to manage blood sugar and hunger. And Glucerna Hunger Smart has a blend of slow-release carbohydrates designed to minimize blood sugar spikes. It contains 15 grams of protein to help manage hunger. It has antioxidants, vitamin C, E, and selenium to support immune health. And it's 180 calories in 10 fluid ounces, and it comes in assorted flavors. As with most of Abbott's products, Glucerna Hunger Smart is kosher and halal prepared and is suitable for lactose intolerance. So please recommend Glucerna products for your patients as part of their diabetes management plan. I have included my business card, so please contact me if you have any questions, queries, or concerns regarding any of Abbott's nutritional products. My cell number is 489-6093, and my email address is paul.russell with 1 L @abbott.com. And our products are distributed by Caramed Limited at 20 Lady Musgrave Road. And I thank you for your time.
Thank you so much, Paul. Can we have a more now?
Good day, this is Health 2000 Canada, otherwise known as H2K. H2K pentoxifillin extended release 400 milligram tablets, a hemorrhagic agent that works by helping blood flow more easily through narrowed arteries. H2K pentoxifillin treats problems from poor blood circulation. It reduces pain, cramping, numbness, and weakness in the arms or legs, which occur due to intermittent claudication. H2K pentoxifillin.
H2K meloxicam tablets, a non-steroidal anti-inflammatory, used to relieve inflammation, chronic pain, tenderness, swelling, and stiffness caused by osteoarthritis. With its easy once-a-day dosing, life can be enjoyed again with effective pain management. H2K meloxicam.
H2K ibuprofen 400 and 600 milligram tablets for safe, effective routine management of pain and inflammation, be it acute arthritic pain, acute low back pain, sports injuries, fractures and dislocations, dental pain, body ache or headache. No pain is out of reach with H2K ibuprofen.
Or Total Neem Cream, a fast-healing herbal skin cream made with natural ingredients such as neem, aloe vera, sesame seed oil, zinc, asoka, and licorice that helps to reduce topical pain, calms minor skin inflammation, treats minor skin infection, and promotes healing. Boratotal's powerful natural ingredients work together to heal skin issues fast and prevent further infection from bug bites, cuts, scratches, and burns, dry, cracked skin, sunburns, and is sensitive, skin-friendly. Try Boratotal. pain relief with Go-Gel. For arthritis, neck pain, back pain, Go-Gel's non-greasy, safe formula delivers medication on site. No prescription needed. So keep going and go beyond your limits. Go-Gel.
Are you feeling tired and weak? Not eating properly? Recovering from an illness? Take Vitamax, the complete sugar-free multivitamin mineral syrup with over 15 essential vitamins and minerals the body requires daily. Take Vitamax to boost your immune system, enhance your appetite, and boost performance with added antioxidant support. Kids love the taste, adults love the benefits. Vitamax, for overall good health in one spoonful. Vitamax, the complete supplement for the whole family.
All our products are available in pharmacies island-wide. Doctors, please write H2K before the drug name on your prescription. Nurses and other members of the medical fraternity and the public, please ask for the H2K brand. Please follow us on Facebook and Instagram. Thank you for including us in your symposium. Have a great day.
Thank you for being a part of our symposium, as well to H2K products, as well as Abbott through CariMed. Now we go on to our next speaker, and that is Dr. Keisha Davis King. And she's here and ready. Keisha, not seeing you yet. Can you hear me? Sam, okay, there's Keisha. She's getting ready now. Dr. Keisha Davis King is a consultant rheumatologist and medical internist at the Eric Williams Medical Science Complex, with over 10 years of clinical experience in internal medicine. She pursued her subspecialty in rheumatology and is the current president of the Caribbean Association of Rheumatology, aiming to increase awareness of rheumatological conditions among the general population and provide high quality care for patients using advanced medical techniques. Dr. Davis King is also an associate lecturer with the University of the West Indies. She is a graduate of the University of the West Indies and holding an MBBS in medicine, honors degree. And she also completed her rheumatology fellowship and specialty certificate examination in the UK. So earlier we had from the North Caribbean, from Bahamas. Now we have from the Southern Caribbean, from Trinidad, Dr. Keisha Davis. And yes, if we didn't have enough pain, we have more to expect. She's going to talk to us about gout. Please go ahead, Dr. Davis.
Thank you for the introduction. And thank you so much for having me. Can you all hear me clearly?
Yes, we are hearing you clearly. And your slide is up. We can see it. Go ahead, please. Right. Thank you.
So again, I'm Keisha Davis King, and I'd like to start off a presentation as near and dear to my heart, and I guess a lot of you all. And something that we see quite commonly. It's a condition well known to us. So just some updates in terms of management. I'll start off by introducing what is gout, how we diagnose gout, treatment options available, prevention, and a bit of a snapshot from the American College of Rheumatology guidelines. We also discuss complications and then a summary. All right, so how do we define gout? So gout is an inflammatory arthritis which occurs from monosodium urate deposition, right? There are certain risk factors of certain persons who are more predisposed to gout, men more than female. It's almost never seen in childhood. Diet rich in purines, elevated BMI, certain medications and medical conditions. So they usually occur in patients with multiple comorbidities such as diabetes, high blood pressure, and renal impairment. So this would be our target population, which we suspect possibility of gout. just a bit of the pathophysiology. So basically, you may have a diet high in purines or increased cell breakdown, thereby leading to uric acid. Now, some people may overproduce or under-excrete uric acid, but ultimately the pathophysiology starts from hyperuricemia, with deposition either in the kidneys, soft tissue or joints, or other tissues which we identify as tophi. Now, what are the symptoms of gout? As we rheumatologists, we usually see a lot of inflammatory arthritis picture, and I like to spend time in terms of differentiating what does the inflammatory arthritis from gout looks like, say, for instance, rheumatoid arthritis or psoriatic arthritis, right? It's recurrent flares of inflammation, or you can get a chronic arthropathy, and there's accumulation of crystals in the form of tophaceous deposits. You can have kidney involvement based on deposition of the uric acids causing kidney stones or chronic nephropathy, which is an entity that is discussed but may also be contributed from comorbid states that these patients may have. There are 3 classic clinical stages. Now, firstly, as mentioned before in pathophysiology, there's elevated high uric acid levels. There's been some debate in terms of patients with hyperuricemia. It is considered now part and parcel of the metabolic syndrome. However, as per guidelines, it's not treated until it causes an issue, right? So this is where we start in terms of gout flares, where symptoms occur. It's usually acute painful joint. Then there's intercritical gout, where periods of remission, and then there's chronic gout, which is gout pain, which is frequent, and tophaceous deposits in joints. So how do we diagnose gout, right? There's a clinical history, examination, laboratory investigation, radiologic tools, and synovial fluid analysis, right? In terms of the history, I usually advise patients, or when taking the advice doctors when taking the history, it's an acute onset of pain, right? It's quite dramatic. The joint is very tender, hot, swollen, unable to touch the joint, versus a more indolent case of some of the other inflammatory arthritis. The typical joint that is involved is the MTP joint, the metatarsal phalangeal or the big toe joint. However, gout can occur anywhere, sometimes midfoot, ankles, knees, hands, and it can mimic an rheumatoid arthritis or inflammatory type arthropathy. In terms of examination, it's a warm, tender, swollen joints, laboratory investigations, complete blood count may have elevated white cell count, inflammation levels can be elevated, such as a ESR, CRP, and it's also imperative to rule out septic arthritis. In terms of radiology, there are certain pictures on the radiograph that looks typical for gout, and synovial fluid analysis, whereby we extract some of the synovial fluid, we look under a microscope, and we're looking for negative birefringent under polarized light. So this is an X-ray where we can clearly see the gouty tophi. If we also look into the joints here and here and here, they are punched out lesions. There's also erosion into the bone, as well as loss of your joint space compared to, say, these other joints. Yeah, so there's tophaceous deposition as well as punched out lesions. As time progresses, musculoskeletal ultrasound, it's a tool that is more and more readily available. However, it is user dependent, but can be used by rheumatologists to give us an idea of and help in the diagnostic approach of gout. If we look at this picture here, there's what we call a double contour sign. So there are 2 clear lines that's seen. This is actually cartilage, the black area, and what this represents is the interface that you see on ultrasound actually showing gout deposition. And this is, you're actually seeing, this is actually a picture of the tophi itself, and the positive Doppler sign also gives us an idea of active inflammation. MRI can be used as well to locate crystals, as well as dual energy CT. However, these are not readily available and quite costly, especially in regions like ourselves. Part of the treatment, there is part of it's a holistic approach. Lifestyle changes are very important. Some patients would mention when they certain meals they take, food like for instance red meat or alcoholic beverages such as beers can precipitate attacks. So it'd be mindful in terms of when counseling patients, lifestyle and dietary adjustments are necessary. There's also the acute gout management as well as preventative management and modifying risk factors. This is important because acute gout treatment doesn't actually deal with the problem in terms of hyperuricemia. However, it does address pain that may be present at that time. For the patient, it is the most dramatic complaint, which is, and we can use anti-inflammatories, colchicine, as well as steroids. For prevention of recurrent attacks, this is where we look at your urate-lowering therapies, such as xanthine oxidase or urocosuric acid agents. Urocosuric agents. This is just a look at some of the urate-lowering therapies for gout. Allopurinol is first line option for all patients. Most common is a xanthine oxidase inhibitor. You usually start at less than 100 milligrams and you up titrate until the desired uric acid target is achieved. Be mindful, as I mentioned before, a lot of these patients can have comorbid conditions. As such, look out for chronic kidney disease where there may be a need for adjustment of your allopurinol dosing. Febuxostat is another xanthine oxidase inhibitor that can be used. Usually start at less than 40 milligrams up to a maximum dose of 80 milligrams. But this is actually quite, this is more used in the States. I'm not sure what is the availability in Jamaica. Probenecid can be used. And pegloticase, which is a monoclonal antibody, but we'll touch on that later. Yeah, and these are not recommended for first-line agents. So in terms of prevention, as I mentioned before, lifestyle changes and modifications are very important. And as part of counseling patients, we need to advise them of such in terms of, and as well, the rules of the medications that they may take. Some patients, because they feel well when they take the anti-inflammatories, colchicine or steroids, they may not understand the value in terms of using these anti-oxidase inhibitors. So it's clear, it should be clear, in addition to lifestyle, the role of each medication. Treating acutely in terms of when they have a fear and compliance with these anti-oxidase inhibitors. In my practice, I have some patients, for whatever reason, they assume that their allopurinol is meant to be used for acute flares, so they take it PRN or sporadically, and of course, it's not effective. And then they report it's not being effective, but it's actually not being used as it's meant to be used. As such, now we look at the American College, some snapshot of some important data from the American College of Rheumatology recommendations, right? So who do we start it on? When do we start, right? So patients who experience a gout flare, they strongly recommend oral colchicine, NSAIDs, or steroids, as mentioned before. Now, steroids can be administered via mouth, intra-articular, or intramuscularly, right? And these are first lines. There are a lot of chat about the IL-1 inhibitors, especially anakinra, which is not available in the region, but sometimes used in the States, but is not first line, right? When we administer colchicine, previous recommendations suggested quite a heavy loading dose of colchicine until the patient has GI symptoms. However, guidelines have updated where we prefer low dose colchicine, which is similarly effective. For patients who are unable to tolerate first line, then we recommend the IL-1 inhibition, which would be like the anakinra. And for patients who are unable to tolerate anything orally, remember steroids can be administered intramuscularly or intravenously or intra-articularly. Yeah. So in terms of lifestyle modifications, recommend limiting alcohol intake, purine-rich foods, foods high in high fructose corn syrup, And for patients who are overweight or obese, regardless of disease activity, we recommend weight loss. As I mentioned earlier, hyperuricemia is thought to be part and parcel of the metabolic syndrome. So there's a lot of investigation into uric acid as a metabolic marker. For patients with gout, in terms of who have comorbid disease, if, for instance, if they're not diuretic, an ARB can be switched to manage their blood pressure. Solosartan is an example. There's no need to stop aspirin, and there's no need to switch the fenofibrate. In terms of the complications, so we look at gout. We know it's quite a dramatic arthritis, but we need to be mindful that it does impact quality of life of patients quite significantly. That's one aspect. There's also actual joint damage and destruction, which can lead to deformity over time and decreased mobility in respective regions in terms of where it's affected. Tophi can be deposited too as well, which can have cosmetic as well as physical implications. And kidney and heart disease are also some of the complications from gout. In terms of looking at the newer treatment, I think we're well aware gout has been here a while. We are well familiar with the anti-inflammatories. The anti-inflammatories is steroids and colchicine. However, anakinra is an option, albeit not first line, but they're for these patients who are very difficult to treat. It's an IL-1 antagonist, and it's 100 milligrams given daily for 5 consecutive days. And canakinumab is a monoclonal antibody too as well, licensed in the European Union, which can be used for refractory gout flares. So in conclusion, gout is an inflammatory arthritis, more common in males than females. When managing said patients, prevention as well as lifestyle modifications is just as important as discussing medical treatments. And of note, there are a lot of newer developments in terms of gout management. So just look out, and in terms of when to refer, when cases seem complex or patients with extreme tophi, we could always touch base with your rheumatologist in terms of management options. And that's it for me. Thank you.
All right. Thank you so much, Dr. Davis.
Are there any questions?
And we're going to look at the questions. I think you were very to the point, concise, and very useful information. We're going to look at some of the questions. I'm looking, where are we? I think, I'm trying to look at the questions to see if I see any more. Let's see, I see a question which can be applied to almost everything. Is there a support group for patients, not just with rheumatoid or lupus? We hear about these groups, but for gout or for psoriatic arthritis. So either Dr. Roll or Dr. Davis King can answer. Do we have support groups for these people?
Well, I could speak for Ultra Bahamas, and this is based on discussions from Caribbean Association of Rheumatology. There's not much support group in Trinidad in particular for inflammatory arthritis, right? Inflammatory arthritis, we're looking at rheumatoid, psoriatic, or even gout. Lupus usually takes the forefront, and we do have support groups for lupus, and these patients also experience inflammatory arthritis. However, there's not a specific group primarily for the arthritis.
Yes, and bear in mind, these persons suffer greatly. Persons with gout all suffer greatly, but we should not ignore the fact that persons with gout suffer greatly as well. I remember a patient, and I suggested that changing to an ARB would help to lower her, perhaps lower the uric acid. And she was so, impressed. She was like, I have to have that antihypertensive now because I don't want to have another attack of gout. And it was like the memory was terrible.
I think, yeah, that's a very important point. And sometimes because it's relatively common that we forget the debilitating aspects, and it's actually one of the most dramatic. Now, rheumatoid and psoriatic, they can be quite dramatic too as well, but the onset of gout is like that, especially if it's first time. So this sudden rise from today to wake up in the morning, this extreme pain, it does affect the patients quite psychologically. And that's why it's also important to, when counseling them, to advise on rescue therapy. Sometimes I may give them, although we start urine therapy, I may give them like a prednisolone rescue packet. Should they need a rise, they can use.
Thank you. Any more questions, Sam? Have I missed any? Just wondered, in case of psoriasis, for the general practitioner, you meant, the quick cocktail, somebody who you realize this is psoriasis and the arthritis is linked, more likely linked to the psoriasis. Is there a cocktail or a package similar to what we have for gout that we could start the patients while we wait for the referral to take place through our slow hospital system?
Good question, Dr. Green. There's no specific package, but there are things that you can do for patients that don't have any contraindications when they have active flare, particularly for peripheral arthritis, meaning their hands, small hand joints, feet, large joints. We can give them steroids. Many persons have a lot of contraindications, especially as you go up in age to NSAIDs because of renal insufficiency and because of GI issues, whether it be gastritis or ulcers. So sometimes, even if the patient is diabetic and we can get good control, we start off with at least steroids that you could start the patient on to help quiet or calm down their disease. And then ultimately, it's determining, is this patient, do they have enough joint damage, or not damage, I should say, but enough joint involvement before we get to damage, as well as any other type of systemic symptoms to warrant like DMARD therapy, like I had mentioned before, like methotrexate and sulfasalazine, some of the other things that we talked about before they get to some of the bigger drugs like the biologics.
Thank you. I'd like both of you to comment on a little bit more on diet. We heard for rheumatoid, probably the Mediterranean diet. We heard about the dysbiosis of the the whole biome of the gut, etc. So could you both say some more about diet for patients?
Sure, I'll go first. Diet is extremely important, although many of us, particularly in our culture, we think that diet is the only factor. But like I had pointed out before, in many of these diseases, autoimmune, connective tissue disease, inflammatory arthritis, there are many other environmental and social, as well as genetic predispositions that cause to have activity or cause disease onset, and also determine sometimes even how active disease might be. But the diet is still important in terms of trying to control all the different aspects that might contribute to the patient's well-being. And so for patients with, for example, psoriatic arthritis, other inflammatory arthritis that are chronic like rheumatoid, etc., trying to adopt a low inflammatory diet is a very important thing. And so usually I tell patients, try to avoid processed foods, try to avoid excess sugars, because those things increase the risk of inflammation, and so usually most studies have shown have a poor outcome in the long term. And then apart from that, you want them to have a healthier diet, a diet that encompasses, a good amount of your whole grains, your wheats, your fruits and vegetables. And so most studies have shown that a Mediterranean diet is actually one of the best sources, olive oil, low in red meat, low in excessive alcohol, having more less refined sugars, etc., and having more wheat in the diet, fruits and vegetables, and lean meat like fish and chicken and turkey. So those things help. And I just want to mention something, this is off the diet issue. Gout can be more debilitating sometimes than even the more fancy inflammatory arthritis. I just had a patient literally last week because people forget that, yes, it's a common disease, but the patient was wheelchair bound because he had complete ankylosis of his knees. And so now, these are the things that in this day and age we try to avoid. And most people, they talk about avoiding the red meat, alcohol, but those things alone, although important, are not sufficient to completely control a disease the way you have severe tophaceous deposits or you have recurrent flares.
Thank you. Dr. Davis King.
Yes, that's an excellent question. And just to piggyback a bit on what Anishka said, inflammatory arthritis with psoriatic is one. I advise as well, right? On process your diet as much as possible. So avoid refined food, processed foods. And then I tell patients you'll have to also look at your diet for things that are specific to you, right? Patients, so anecdotally, things that I see, they report sugars, they refined food. And people, for instance, tomatoes, they may precipitate up. Some patients said melangen. So I said there are general rules, but every individual is different. As such, you have to also pay attention to your personal triggers, right? Now, although when we as physicians speak to patients, we tell them what not to eat, a lot of them want to know what they eat, especially in the Caribbean diet where we're extremely carb heavy. I don't know if you all, a Christmas meal or Sunday lunch is, yes, you have protein, veggies, yes, you may have a light salad, but macaroni pie, fried, so it's extremely carb heavy. So when you advise patients to remove these things, they're now like, what can I eat, right? So it's also redefining in terms of what your breakfast may look like, in terms of protein, maybe the center versus carbs. So a lot of discussions need to be had surrounding that and taken in terms of the cultural aspect. So yes, we see a Mediterranean diet, but most people in the Caribbean probably we don't eat anything close to a Mediterranean diet, right? So it's difficult for them to draw a reference in terms of it being practical. So I also spend time on that in terms of meat, beans, and there's also the cost in terms of what is available. So even things like sweet potato, even potatoes, but everything in moderation. So try to give them an idea in terms of what your plate could look like, which is a little different from what we know, what mommy might say, what granny might say. So that's why I spent some time in discussing in terms of inflammatory arthritis. Gout follows along the same trend in terms of, but there are specific things like alcohol as well as the red meats to avoid. But if we take all holistically, I mean, if we could eat just a cleaner, unprocessed diet, I think that will encompass everything else. And also be aware, we may say those words, but some people don't know what processed means in terms of like the practical, what, and I'm sure you all probably would experience that as well.
Yes. Thank you all so very much. And now we're going to hand over to our person giving the vote of thanks. Who is that, Sam? I'm not quite sure.
Thank you.
Thank you so much to everybody and all the presenters. It's to be Dr. Dane Levy, not seeing him online. Wonderful gentleman. I'm sure he had an emergency and we apologize for his absence. If you will allow me, Dr. Ananuju and Dr. Williams Green. I would like to take the opportunity to say thank you to everyone, all of our moderators, Dr. Aileen Standard Goldson and Dr. Pauline Williams Green. Wonderful moderation by you. Of course, our presenters, Dr. Stacey Davis, Dr. Tanisha McGee, Dr. Anish Karol, and Dr. Keisha Davis King. Wonderful presentations, really active Q&A sections as well. So I want to thank all of our attendees for being here, being online, being on time, being attentive. I think there was a lot that was learned today, not just information that you already knew. We want to thank Dr. Arna J. Brown Morgan for her prayer earlier, and of course, Dr. Onanuju for what she has done in the background to put together such a wonderful program for everyone. Of course, we want to thank Lynn, who is there in the background, always ensuring everything runs smoothly. And of course, without sponsors, this is not possible. So we want to thank our sponsors who came on board to ensure that today could happen. That's the CariMed Group, Medimpex, Abbott Nutritionals, and H2K. So thank you to everyone. The post test is now shared in the chat. Please go ahead, do it at your leisure, and feel free to reach out to Lynn if you have any questions about how to get your CMEs. Thank you all so much. Have a wonderful day. Summer is fast ending, but we give thanks for that because of the heat. Dr. Williams Green, it's hot.
Yes.
So we want to go to a river or a beach later and enjoy the rest of summer. See you guys at our next event. Thank you all so much. Stay safe, everyone.
Tam, I see someone saying the post test is not opening, unable to access.
Send it again, please.
Okay, no problem.
I just want to add our thanks, our sincere thanks to Sam and his team for always being there. It's not just what they do on the day, but what is done in preparation as well. And we do appreciate his ongoing support in all of these webinars. Thank you very much, Mr. Harold.
Thank you so much, Doc. I appreciate it.
Ditto. Thank you.